All right, so good morning, everyone. I know we introduced ourselves a little bit earlier. I'm Allison Swigert. I'm here with Julie Graziani. We're both psychiatrists with Penn State Health, working at PPI, Pennsylvania Psychiatric Institute in Harrisburg locally, myself on the outpatient side and Julie on the inpatient side. And we're really excited to be talking with you today about mobilizing the mental health vote. We are setting a precedent by sitting down, which will allow the next panel to do the same. And I've also been given a handy dandy clicker. Lots of new and exciting things for this presentation. All right, so Julie and I are going to tag team. We are also going to be asking for your participation and discussion at 2 different points through the presentation. So briefly, our objectives are to understand the relationship between voting and health, to identify barriers that individuals with mental illness may encounter when exercising their right to vote. And then finally, we want you to be able to take away an action step for you or your organization to become more civically engaged and facilitate access to voting for individuals with mental health conditions. So here's our brief agenda, which we're going to try to stick to. So we're going to first briefly go over voting, the relationship between voting and mental health and the barriers encountered. And then Dr. Graziani will talk about PPI's civic wellness and voter support program that she has been heading for the last few years. We're going to take a break for some large group discussion, come back and do a little bit on voter communication and education, and then finally conclude with some more discussion and action step identification. So I'm going to take the first part here, our brief overview. We pared this down a lot because I don't think we need to do a whole lot of convincing to the members of this audience. But obviously voting can have a big impact on multiple levels of health, including the structural determinants of health, social determinants of health, and also the health of the individual. So taking those just a little bit in turn, there is a little bit of literature on the beneficial effects of voting on health. And in terms of the mental health sphere, for those with mental health conditions, voting can foster a sense of empowerment. It can also foster a sense of social connection and inclusion and community. Individuals who vote tend to have better self-reported health. And there's been a couple of longitudinal studies that's showing that when individuals vote early in adulthood, they tend to have fewer depressive symptoms and less risky health-related behaviors. So we can see that voting can be beneficial to psychological health. There's also just a little bit in the literature about voting as part of recovery for individuals with mental health conditions. So there's a neat qualitative study that looked at focus groups of people who are receiving care in the public mental health care system in New York City. Took summed up qualitatively what those individuals had to say about voting. And a couple themes that emerged were that voting and political participation is symbolic of inclusion, particularly for minority or marginalized groups who have been historically disenfranchised and excluded from the political process. And also the idea that voting is really important in overcoming these legacies of discrimination, specifically, especially for marginalized group, and also talked about how you can sort of at a larger sense almost develop a disability voting block that can help address the concerns of everyone with different types of disabilities so that their needs are met by the community and by society. So stepping back sort of more broadly, we can think about the concept of civic health. which is defined as the ways in which residents of a community participate in activities that strengthen well-being, enhance interconnectedness, build trust, help each other, talk about public issues and challenges, and also problem solve them, volunteer, stay informed, and participate in crafting solutions to challenges that the communities face. So civic health includes a number of different components, including that idea of social connectedness, community engagement, community involvement, and then also political action and participation. So this is a really interesting website, the Health and Democracy Index, which you can take a look at and play around with. So this looks at 12 public health indicators of various states, such as health, self-rated health and mental health, premature mortality, infant mortality, prevalence of chronic disease, number of physicians per capita, poverty, community and family safety, and correlates them with voting access, or sort of looking at voting law restrictions. So I even have a pointer. So it's plotted as up here on the top half of the graph are sort of better public health outcomes or indicators, and down here worse public health outcomes or indicators, and then towards the left of the graph, more voting access, so states that have less restrictive voting laws, so that might include things like the ease of automatic registration, reenfranchisement to vote for people who've been convicted of felonies previously, mail-in ballots, less strict voter ID laws, and then on the right side, we have less voting access. So Pennsylvania here is represented by the purple star, kind of in the middle. So definitely more work can be done there for us. And there are a couple slides later on that address some of these voting law indicators, or voting laws within Pennsulvania, to give a little bit more guidance about that. Yes, Ken.
The states that are doing really well, what are they?
Oh, what are these
tell?
up here? Over here?
Yeah.
So we have, up here we have Massachusetts, Vermont, Hawaii, Utah, Washington, Oregon, Maryland, Colorado, Illinois, California, North Dakota.
And the higher up they are, the better the health.
Yeah, so better health is better public health indicators is above this line, and worse health indicators is below this line. And I think you had checked this. This is pulled from a couple years ago, so it was actually right before Governor Shapiro put the initiative into do automatic or sort of opt-out registration at DMVs. And it hasn't really, I don't think this is updated. Yeah, I don't think the indicator has been updated. So it's possible Pennsylvania could move a little bit more along this line, although obviously that law has been a subject of contention.
And we don't know that it's actually helped our.
Not yet. I mean, it's really very new.
But this is horrible.
Yeah.
I don't want to, you put us in the middle of the pack. That's not okay. That's terrible.
Yeah.
Mhm.
This is such a cool website that this is where I also tell people, if they start to get bored with our presentation, which hopefully you won't, to at least go to this website and play around with it and see like where we fall, because it'll go state by state. And it looks at all the different indicators and ease of voting access.
Yeah, so it'll also allow, you can click on some of the states that are doing better in terms of health indicators and see what are some of the differences there.
What's the per capita income line on that too?
That's
Per capita income.
Yeah, that's a good question, right?
That's what I'm
So yeah, I mean, you can, so the ones that are doing worse, Missouri, Arkansas, Alabama, Oklahoma, West Virginia, I don't know what that one is, Louisiana.
Mississippi.
Yeah, oh, that's Mississippi, okay. Sort of got overlapped on the slide. Yep, so that's certainly a component of it as well. All right. And so we talked a little bit about voting, trying to do two things at once. So we talked a little bit about voting impact on individuals' health. Obviously, I don't need to convince you guys that voting impacts the social determinants of health. You may be aware that this connection between voting and health is considered so critical that in 2022, the AMA, the American Medical Association, acknowledged, declared voting to be a social determinant of health, and recommended broad access to it as a way of improving public health. And then on an even broader level, voting also influences the structural determinants of health, which are the policies and laws that help govern the social determinants of health. So that can include decisions about pollution emissions, government subsidies for healthcare or education, decisions about the built environment around us, safe housing, transportation, and safety of neighborhoods. All right, and then we're gonna move on to understanding a little bit about why people might not vote or what are the barriers to voting. So if we go back to the 2020 election, in the general population, about a third of citizens who were eligible to vote did not vote in the 2020 election. And we know from data that voting turnout varies by racial identity, age, educational level, and income levels. So voter turnout in the 2020 election was lower among Black, Latino, and American Indian individuals, those of younger age, and then individuals with lower education levels and lower income levels. And we can see that these same barriers to voting can also be social determinants of mental health or risk factors for the development of mental health conditions. So we see really how these health disparities and voting access are linked. All right. There is a little bit of literature about voting practices among patients with mental health conditions. What that has generally found is that those who are psychiatric patients are even less likely than the average citizen to be registered to vote. And that commonly the reasons for that are cited are not knowing how to register to vote, or lack of awareness of their right to vote. Oh, I'm sorry. Thank you. And having the right to vote is also different than being able to exercise the right to vote. So some common reasons that individuals with mental health conditions might not be voting are listed up here. So we talked about not knowing how to register to vote, or the lack of awareness to vote, but also not surprisingly, unstable housing, having a disability or illness, and that could include having comorbidities of medical conditions, lack of identification, which is still something that is impacting access to voting in Pennsylvania, because the first time you vote in person, you are required to present an ID, going to the incorrect polling place or not knowing where to go, and lack of transportation to the polls. And so with that, I am going to turn it over to Dr. Graziani to talk about our project at PPA.
Can I ask a quick question? Do they, when you're talking about that, do they accept, like, obviously, if you don't have a place to live, do they accept like if homeless shelter addresses or PO boxes?
Yeah, we have a slide about that.
Okay.
Mhm.
Not a
That's
PO box,
not a PO.
but you need a physical address.
Because I'm sure to talk about it, but that's
Yeah.
obviously an issue.
Yeah. So we've kind of taken this bird's eye view of kind of voting and psychiatric illness, but the question is, what does that mean for the actual patients that we treat here in Pennsylvania? And so, like Elliot said, we are at PPI, which is an academically affiliated community psychiatric hospital and clinic in Harrisburg, the capital of Pennsylvania. We have 64 licensed adult acute psychiatric beds, as well as outpatient and partial hospital programs. So we started our 2020 voter support program on the inpatient units. And we're going to talk about this survey that went along with this voter support program, but it was offered to all of the adult inpatients for 6 weeks prior to the 2020 hospital or the 2020 general election. And we had 119 adult inpatients actually fill out that survey. So in that population, and it was a 68% response rate, an estimated 80% of this population was registered to vote. However, in the survey, when we said, are you registered to vote? Only 65% of them said yes, right? Through the action of a voter support activity, which included things like checking your voter registration, another 15% realized that they actually were registered to vote, but they didn't think that they were, right? So that's wonderful. However, what you want to then do is compare that 80% of that population to the fact that in the 2016 election, 87.07% of voting age Pennsylvanians were registered to vote. So we're starting to see a little bit of a discrepancy there. So that's voter registration. Yeah, someone said large. Thank you for that. So then that's voter registration. What we also want to think about is actual voting. So in 2016, in the 2020 survey, we said, did you vote in the 2016 election? 51% of the patients who filled out that survey said yes. The state data showed that 61% of voting age Pennsylvanians reported voting in the 2016 election. So we have an even larger discrepancy there. So we have voter registration and we have the active voting. So we also wanted to know, well, what barriers have you encountered when it comes to voting in the past? And we gave individuals the option of 14 different barriers, and they could rate them from never experiencing them to sometimes to always. And what we found was that only like 28 people had never experienced any sort of barrier to voting in the past. That is a very small number of people. And on the x-axis, we have, number of previous different unique barriers encountered. And you can see that a good chunk of our people had experienced between 1 to 8 different sorts of barriers, like I didn't have ID, I didn't know where my polling place was, I didn't have transportation to the polls, I couldn't read, things like that. We also looked at, had you experienced barriers and did you vote in the 2016 election, right? And so for the people who did vote in 2016, they had experienced an average of 1.72 barriers in the past. For those who did not vote in 2016, they had experienced 3.4 perceived barriers. So you can start to see how the number of barriers are also affecting people's ability to vote. We also had some biostatisticians look at this data, and that is a significant number. So everybody loves significance here, right? So this was a significant finding, both biostatistically, but also when we think about the community at large. Ali had talked about, why are people not voting and how rates of voting are lower in people with lower education, in people of color. And we see this magnified in our population as well. So this was, the end was 119, and we can see that these red highlighted looks at the number of the main barriers, right? And so you can see in people who had an associate's degree or some college or less versus those with a bachelor degree, they had 2.8 versus 1.9 barriers. When we look at racial identity, we see that individuals who identified as African American had 4.4 previous barriers encountered, as opposed to 1.8 in individuals who identified as white. This is kind of looking at those same numbers, just cut a different way. In individuals who identified as white, 45% had 1 to 2 barriers, as opposed to those who identified as African American. We had 71.4% have 3 or more barriers in the past when it comes to voting. So we see that there are these barriers in our patients and the people that we work with. So what can we do about it? So the National Voter Registration Act of 1993, also called the Motor Voter Law, which is why you can register to vote at the DMV, allows for public assistance offices to offer voter registration. And a public assistance office is one which provides services under any public assistance program, like Medicaid or the state children's health insurance program. And then the IRS tax code also allows for 501c3 organizations to conduct voter registration, provided they are conducted, and this is the big important part, in a neutral and nonpartisan manner. So all of the voter support activities that we offer and have completed at PPI are done in a neutral and nonpartisan manner. So what does that mean? It means we do not endorse specific political parties, candidates, or policies, and we respect the different affiliations of any person we speak about. Yes,
Question.
yeah.
I feel like voter registration in general is always partisan because one party is actively engaged in disenfranchisement. And so I've never in my life heard a member of the Republican Party say, we really gotta get.
That's their problem, right? You know? They're allowed to say that.
Actually, that's not quite accurate, because
Yeah.
I've been, when I moved to a new place, years ago, when I was a resident and moved to Jenkintown and had to get re-registered. Jenkintown's outside of Philadelphia. And there was pressure for me to move from my Democratic, identification to a Republican identification. And because I was singular in the room with all of these older people at the time, for a very small minute, I was a Republican. So I'm just saying there is.
Registered as a Republican.
Yes, yes.
That's like, so you could infiltrate from.
Well, there are places where in order to influence sort of local politics or government, sometimes people do register with a different party in order to be able to have an influence there.
There is I mean, out in rural Pennsylvania, there are shops that are registering.
And there are
That
some
not-
efforts.
That are doing
for
it,
mail ballot.
you know, it's parties who organize this, but in general, but it's,
To reiterate, I've never seen it, but I've
Yeah.
also never gone to rural. I was supposed to go to rural Nebraska for med school once, and then have to go back, but like, I'm not in rural places.
You're in a rural place, but again. Yeah. Highly Republican area right
Yeah.
now.
Yeah, but it's not
high,
you don't want more Pittsburgh.
No.
So they're not.
Right.
And I think that actually brings up a good point in the sense that people hear voter registration and they think that it comes with a political bend, right? But the fact of the matter is, it does not come with a political bend. We'll talk about some of our voter support activities, but one of them is a voter registration day drive that we do every year, and it's staffed by medical students. And each year we do kind of a debriefing with the medical students, and a central theme that has come up now 2 years in a row is that they realize that there's not a lot of political hot air when they're actually doing the voter registration. So they're like gearing up for these like scary conversations about why are you registering people to vote in a hospital? And what they come out of the experience realizing is that it's just a community support activity, which I think is really important to kind of think about and to kind of be able to take a step away from this political hot button of voter registration. Yeah.
Well, and like you said, it's supposed to be, but then there are still, and there's a lot of groups, I guess, that aren't as powerful anymore. You don't hear about it, like the League of Women Voters used to have voter guides. They used to always do that. And if you-
They still do.
And if you go to places like, I was at the Green Day concert, and they have things to vote, people can
Mhm.
vote, you know, it's unfortunate or fortunate, usually, even though it is like, say, women voters or other voters, there's still generally a bend, only people think it's a bend because they know the issues are Democratic or Republican, but in true theory, it's not supposed to be that way.
Right, so the important piece is to do a voter registration in a healthcare organization, it has to be conducted in a neutral and nonpartisan way.
So what does our voter support and civic wellness program look like at PPI? So we started it in 2020 with our inpatient voter support activity program, called them VSAs for short. But the VSAs are highlighted in this box. And so what happens is we have a team of volunteer medical students and myself, and we check in with every hospitalized inpatient in our hospital during those 6 weeks prior to the election, we say, we have this voter support program. Are you interested in doing any of these voter support activities? And if they are, we'll sit down and we'll do this with them. And a lot of it is actually problem solving too. So for example, the other day I was doing one with a lady and she said, well, when I tried to vote in another state, I have trouble reading. And they said, nobody could help me there. Nobody could help me at the polls. And so I said, I don't think that's the case here in Pennsylvania. And so we called up the county election office together. She asked her questions, said, will someone help me vote, vote if I have trouble reading? And they said yes. And so this is like us providing support to our patients and helping them make a plan to vote. We also offer them the opportunity to complete an electronic voter registration application or a paper one or request a mail-in ballot. We are a Civic Health Month partner. So every August, and this is actually now in Pennsylvania too, is Civic Health Month. We provide hospital-wide communications about voter registration and how voting can impact your health. You go into our elevators, you'll see these clings with important election dates. We do a National Voter Registration Day drive. That was September 17th this year. So we just completed our 3rd one that's staffed by medical students from the Penn State College of Medicine. Last year, we started partnering with a local psychosocial rehab program a few blocks away where we offer these voter support activities. We do outpatient education with these cards. We have these floating around. We'll pass them out so you guys can see. And we offer those in our outpatient waiting rooms. We have providers able to take them and give them out to their patients. And what you see is a little thought piece about how voting impacts your health, but also how to make a plan to vote. And then on the back, we include important election day tips and a QR code that will take someone to Turbo Vote to check their voter registration. And then we also provide staff education. So these are some of our examples. The 2 in the middle are the claims that you might see hanging in our hospital elevators and hallways. And then we also use badge backers and lanyards. Allie's modeling them. Thank you. Say ready to vote. Again, it's a thought piece, right? And so it may start a conversation. The badge backer also includes a QR code that we partnered with Vote ER on. And that, you know, at the end of an outpatient appointment, you can say something like, hey, the election is coming up. Like, what's your plan to vote? Are you registered to vote? You can scan this QR code on your way out and find out while you're waiting to book your next appointment. And these are some pictures from our National Voter Registration Day. This was our first one, so it was, you know, still kind of COVID times, so everybody's in their masks. And this is kind of what our patients are saying about this, right? And it really runs the gamut to, I've never had a doctor ask me to register to vote, to I was worried I wouldn't get this done in time because I was here in the hospital, or this is so important that people with mental illness vote, or to just, oh, I'm already a voter, but thank you, right? And so I think it's really important that it highlights the continuum of voting and civic engagement. This slide kind of at the end of our survey, we like to ask people, you know, do you think you'll vote as a result of receiving this support? And we split it up between those who utilized a voter support activity and those who did not. And it was actually like pretty even. 60 people did, 59 people did not. But you can see even the people that did not utilize a voter support activity, when asked that question, a quarter of them still said, yes, I think I may vote as a result of receiving this support. So just the power of having that conversation is really important. Similarly, did this help you think about requesting a mail-in ballot? Almost, you know, a little more than a fifth of people said, yes, it did, even though they didn't utilize a voter support activity. So we've kind of talked about this a little bit, right? About like what's stopping providers. And we did a survey amongst our behavioral health providers in the whole department of Penn State. And the highest endorsed kind of barrier was that people were worried that it would be perceived as political. The second highest endorsed barrier was that they felt like their patients had too many other pressing psychiatric concerns that would take priority in an appointment. What's really interesting is if you go down down to the lowest and worst barrier, I do not think my conversation will change their mind about registering, which means that people actually do think that the conversation may change their patient's mind, but these other barriers are stopping them. So we're gonna pause here for a little bit of a large group discussion. I'm gonna let Ally run that.
So thank you all, been starting to participate already, and I'm just gonna, for the sake of time, I'm just gonna put all three questions out, and, whichever one you'd like to address, feel free to. So, how do you feel about discussing voter registration with your patients when we've had these conversations with, providers, within our institution? There's a range of reactions to it and a range of worries, as Julie was talking about. What barriers do you think you might encounter in becoming more civically engaged or promoting civic engagement within your patient population? And then finally, are there any supports you can identify that might help you promote civic engagement and voting? So we'll open it up. Elizabeth.
So maybe we can go back to some of the earlier comments, and maybe you can comment on damage control and what you've had to do with this activity, which sometimes, even though it's nonpartisan, becomes a lightning rod.
Yes. Recently it has become a lightning rod. And I think we want to get back to why we do it, why it's important. And again, focusing on the data in the sense that there are these barriers, right? We published it, right? Which means it's like really legit in the sense of like, we found this, and there are these barriers, and this is a way that we can help with those barriers in terms of taking care of our patients. And then we also emphasize that this is done in a neutral and nonpartisan manner. So I think it's about figuring out who you're going to engage with in terms of this problem and maintaining the message. Like, do you have others?
I was gonna say, also going back, if you just go back to some of the federal law about it and the Americans with Disabilities Act, these rights are very enshrined and protected. And so I think also kind of stepping back and thinking about that really anyone with any sort of condition has the right to exercise.
So just to close up on this topic, I think it's important to engage the stakeholders that are out there, both within your institution. And for example, we've sent letters to the directors of voting registration across all the counties we work with. So lots of people get information up front before we start each year.
Yeah, County Plan, did you have?
So I had two thoughts. One was, I really liked the way you placed kind of, being a voter in the context of activities of daily life, right? So with an ADL, you registered to vote, do you vote, all those things, right? Can you use public transportation, can you vote? So I like that a whole lot. I was thinking about not recently, about a couple years ago, one of the sort of voter advocacy groups got in touch with us about coming in and registering patients. And I brought it up to our staff. My initial response was, no problem, absolutely right outside the clinic, and we'll encourage people to go your way. But people felt like they shouldn't be in the clinic per se, just for kind of pragmatic reasons. Sort of, the flow, people, don't want to have to think about something different all of a sudden. And, one more thing to do, they just want to talk about the issues they're bringing to their appointment with their, doctor or their therapist. And then I thought, this is a great activity for, certified peer specialists to do it. So anyway, those are my thoughts.
Absolutely, I think it's like you really can frame it as an activity, a step in recovery and like re-engagement with people around you, feeling like you matter and that you have a voice. Kathy?
I think this is so important for our patients because, again, if you're disenfranchised, you have no voice and you're overlooked when the laws are passed.
Right.
And I also am part of Penn State Health, which PPI is part of Penn State Health, but we're in a different hospital. And so I had spoken to Julie about bringing this effort to our outpatient clinic. And I think the two of you, maybe you're gonna get into it later, but you're kind of glossing over the amount of effort this took and the pushback that you had for doing it. But she shared it with us because she said, anticipate this, you're going to get all this, which we didn't get as, and I think partly because it was already in place. But I will say that one of the things that the staff raised the most was the doubt that this could be done, politically neutral. That people, particularly in this very passionate election, would get sucked into sharing their personal opinions. And can they set now, not that this effort is not politically neutral, because it is, but that people have, and you know, how do you handle the fact when somebody says, well, who are you gonna vote for? You know, and I think that's just a really important thing to talk about, is the preparation and the importance of people being able to make this not about vote for my candidate or for the issues that I think are important, and more about empower yourself so that you can do what you need.
Yeah, so to remark on two of those things. One, we are really fortunate that our hospital CMO, Dr. Kunkel, is in our voting work group. So having buy-in from our leadership, she's been a huge proponent of this project, and that has been so incredibly valuable for a multitude of reasons. And then also that idea of being prepared for conversation, right? When someone says, well, who are you voting for? We make sure that all of the medical students that volunteer with us actually sit through an hour-long training where they understand the context where this is coming from, but also we provide them with information about Pennsylvania voting laws, and also how do you respond to a question like that. And in our most recent debriefing from the voter registration drive, a couple students remarked how they were kind of asked those questions and how, you know, the student answered it in a really beautiful fashion. So we want to make sure that our students are prepared. So the answer to that question is, it doesn't matter who I'm voting for. What matters is that you're empowered to vote when the time comes. And we want to make sure our students are really anyone engaging in a voter support activity feel prepared. Yeah.
Well, two things on this. First, I really do think, and I want to emphasize this notion of civic health makes it stand out a little bit as being something that's an add-on. It's actually essential. I mean, you guys have said this. I just really have to drive that home. And I think one of the areas where we need to think about this is that we've gone through this whole move to get people out of institutions into life in the community. And our history has been really bad in that when we get people out of these institutions, we've done nothing to connect them up with the world around them. And we acted as though the relationship that they had with us was the only and most important thing that existed. And whether or not they could go and do something in their communities, I just didn't care, right? I'm just gonna see you in therapy and we'll talk about how there's no place for you to go except your apartment. Okay, so I think this move to thinking about what it is that people actually do when they're living as human beings is really important. And we need to not give up any ground on that at all. That's essential. And civic health, or my own health as a human being, my own mental health, is dependent on how I participate and connect with other activities and things in my world, including the direction of society. Okay, so I just want to emphasize that. Second thing is, I don't think we should disempower ourselves in terms of our conversations with patients and about what we think about things in politics. I'm not advocating that we should be saying, you know, here's who I'm voting for, right? Necessarily, there may be circumstances where I don't have an issue with that, but because it is not necessary to influence people if they've already told you what they're gonna do, right? But I do think that we should not shy away from saying, if you have any questions about mental health policy or concerns about what's happening around mental health, I'm happy to tell you what I understand about the various issues that are going on in mental health right now. And take an educational perspective that we actually know something, and hopefully as a result of today, people will know even more about what some of the mental health concerns are. that are going into legislation or going into the executive, and that we would be the last people to cut ourselves off from telling the constituency who it matters to what is going on. We'd be disempowering them by holding back our opinions to be, they can disagree with us. But I don't think we should hold them back.
And there are ways, I think, to encourage people either to connect with educational materials, and we do have
Yeah.
a slide at the end with that, or we have a colleague in the who's an addiction medicine specialist in our opioid treatment program, and she will tell patients, well, I'm a healthcare voter. I look at the healthcare policies of the candidates, and I vote for people who are gonna make sure that you are able to be here with me and get the care that you need and deserve. So I think there's ways to.
The other thing last thing is that, a medical student who's just meeting somebody for the first time has no treating relationship with them. That's a very different relationship than being your therapist. And I think that they shouldn't have the same rules. It doesn't make sense.
Do the online question.
I have online comment. Appreciate the unique aspects of voting and that we are in election season, but it seems like, excuse me, larger issues is lack of civil engagement. Just talked about a form of social anxiety, isolation, and estrangement at the macro level. It similarly reflected in declining affiliation with religious institutions, fewer voter leads, etc. On a practical level, I think we undervalue prescribing social activities.
What was the last part?
Undervalue
Mm.
prescribing social activities.
Yes, I mean, I think that's a beautiful point. And I think as we're saying, this can be one component of improving, like reducing isolation, improving sense of connection and belonging. And
I think it's very important. I will tell you that I do this with every single patient whenever they complain about anything.
yeah.
They're complaining about why it takes so long for their medications to get authorized and do you, are you registered?
Absolutely, that's a great suggestion. Isaiah, did Isaiah?
So, part of this is my but with barriers that I run into, like talking with patients about this is, and the majority of my patients are Black, and whenever I bring up like voting, it's like, they'll focus mainly on the national stuff. It'll say like, neither candidate has a Black agenda. And there's just kind of apathy from it. And then I will usually say something about, they just repeat the question back to me, and I'm like, well, and I realize I'm not informed enough or really gone in enough myself to like then combat that. And so it's kind of that, like, we talk about like all these barriers, and to even like have the energy to try to overcome the barriers, you have to remove that what's at the end of it is something meaningful. And like, in having conversations in 2016 or in 2020, like no one went to the polls believing the hood was gonna get that. It was, for a lot of people, 2016 in particular, felt like death by 1,000 cuts or death by a blow to the face. How do you prefer your racism over or covert? And so it was really hard to like mobilize the vote amongst Black patients who already have these variables. Like, why would I jump through these hoops just to get something at the end of the road? And so I find, again, my own, I think, frustration with the system makes me not the best person to like motivate patients, because I feel it's really almost comes from an inauthentic place. Because like, for example, I was very excited to vote for John Fetterman. And I strongly regret. And so like, even, people that I believe in, and people are good, right? But, You can stop it. You could get off with it.
Yeah, I mean, I appreciate the honesty in, and the authenticity in speaking that. And I think it actually makes me connect to what Kate Fox was telling us earlier, which is that, you know, we can feel helpless and hopeless, and it's really hard not to get bogged down in that sometimes, but there also are some small steps or actions that we can take, and we can do both, right? I think what Kate was saying, we can do small steps and celebrate the small wins, the conversations you have with someone that move them forward a little bit, while also recognizing that there is a lot of trauma and racism baked into the system, and that very much needs to change too. So,
of course, I'm wondering how you might look at moving forward with this project, how you're being including family, their families or family by choice into this process. Because if they're not registered, most likely families are not. I love the idea of civic engagement. One of the barriers I see is many of the voters don't actually understand civics part. They don't know, like how it functions, how it runs, and why that vote is so important more on a local level consistently than necessarily national. But I don't know how you would build that in. I'm thinking like, how can I build that in? Because I think it's important for people to understand that function, because it's usually not what people do. They think it's like LA law or something.
yeah, well, yeah. You want to
I
talk
think-
about that nominee?
Where they were. Oh, so where we talked to Nami? Or-
Yeah, well, the group, Katie Morton's group,
Yeah.
is trying to
Is that-
Yeah, I
get people.
So with the families, that is one reason why we include things in the waiting rooms, right? And the voter registration day drive actually takes place in all of the lobbies. So in case families are coming in with folks. And then we've been asked to talk to NAMI, the Philadelphia Behavioral Health Advocacy Task Force. And because they're trying to do some voter support and voter registration with their group.
Yeah, that's not nothing.
Oh,
That's a separate.
Okay.
organization.
Well, that can tell you a lot about.
okay.
And I think Katie's on.
Yeah, Katie's on the call. So I mean, I totally, I think loved ones of individuals that we're treating, are a hugely important, group to, get to vote, and also staff, because a lot of the program in the hospital has also been about educating staff and getting them registered to vote too.
I just wanted to respond a little bit to Crystal's point about, what about family members? And I just wanted to say, I love this QR code on here. And part of what I think the empowerment is, to talk to someone, hey, listen, let's look and see if you're registered. And then you can give them this and say, and you can go teach your family.
Right.
That's really
Your friends.
powerful empowerment.
Yeah,
To give them a skill that they can pass on to other people that care for them.
Eileen?
Okay, let me give you two patient stories based on that. So I see children and adolescents, so I have all these adolescents who are 18 or so, just true me. So and I'm gonna add also to the story over there also. So one of them was autistic, gentleman, I think in his early 20s. So he was very happy to get a car to be able to go, because it was like he was hurt. And his mom, his grandmother, who's the caregiver, was there too also. So I got two for one. So I got the grandmother also trying to figure out, okay, am I going to be registered to vote and see how we can make this happen? So that was a good thing. I had another lady, Hispanic lady, which was interesting. She got the card and she looked at it, go and do what she's got, and she looked at it and she did like that. And I'm actually gonna be angry because, no, I already went to the table downstairs and I registered. That's what she's going. Then I had, one who's like 18 with a lot of anxiety. He's interracially mixed, so half black and half white. And I actually had the same kind of reaction he had. Like, I'm not sure what I'm gonna go vote for. He was really looking into this, like this one or the other one. But his main barrier, when I got deep into figuring out what was going on, he didn't have an ID. So he was ashamed that he didn't have an ID at like 19, which is nice right now. So he didn't have an ID at 19, he could drive or anything of that sort, he was living in a hotel, social dynamic, like issues also occurring. So I even told them, look, housing issues, all these issues can be resolved by building. So getting to that barrier is important.
And then I might have to move things along, yeah.
So I just wanted to say, I was listening to NPR the other day and, I have to tell you, I think the Electoral College is a travesty and it's a hangout of the old constitution that was built to actually keep, large numbers of people out rather than be inclusive. However, the Electoral College puts a certain responsibility on Pennsylvania. And the fact that in some of the congressional districts and actually at the state level, this election could potentially come down to a couple of hundred
Yep.
votes.
Oh,
Yep.
So anybody who you get to register makes a difference. I mean, it weirdly puts us in a spot of very small numbers making a very, very large difference.
yes.
And I think that's just something that we should be aware of.
So did you have or you want us to move along, Val, or did you have a comment?
I just wanted to make one last statement.
Yes.
If I could.
Yeah.
To your point about engagement and not feeling like the system's working for you. I think, again, we all have some privilege in this room where we have the ability to help people get connected to ways that their voices can be heard to move the system forward. That's something that even if you're authentically not feeling the choices that you have in front of you, what are the places that you can get into, that you can make change? Even if it's the smallest change, you can see how democracy can actually work. I'm going to point out Ralph, who recently had a success around changing documentation requirements for workers. He solved a problem for me that was 20 years old. I was so moved by that, and I won't want to, you can certainly speak to that if you'd like, Ralph, but by saying this is not something that is working for people, how do I change that? You did.
Yeah, it was a long battle, and I think it came down to a lot of resiliency and belief and luck. And what we were able to do was to change the site rehab regulations to reduce documentation over 100 site rehabs around the state, and the regulation passed last week. So it was a process that I had been working on for about 8 years, and I had to figure out that there was a better way to do it, that other states weren't doing the same thing that we were doing. I had to figure out who was in charge, which I think is what we talked about earlier. Like, who actually holds this thing? The people who hold the strings realize that they have the string power in their hands. And telling them what to do. Like who's the old them. And then figuring out a strategy to meet with other people, make sure everybody's supportive of the change, make sure the change makes sense, and that you're not tearing something down that you're not going to be able to replace it. And then a lot of luck. And we were lucky this time because of, like I was saying earlier, somebody that we definitely could have went the other way very easily. I literally the IRRC voted on the regulation. I wasn't sure which way it was going to go, and the president of Pennsylvania, when I was voting, texted me on the way up and was like, yeah, the people that I know are saying they can find out you guys pretty soon. It's like, brace yourself for the failure. I was like, oh, cool. Great. Now I don't feel any pressure to speak. But it did pass, and it actually gave me a lot of hope because it just means that, we can make changes. A lot of stuff doesn't make sense. A lot of people don't realize that they can make change. But we have to put a lot of work in. It's not going to happen without big work. And then we have to be learning.
Thank you all so much for engaging in the discussion. Congratulations. We're just gonna hit a couple highlights and wrap up, and then we'll make sure the slides are available because a lot of the, like maybe through Lucy can distribute them electronically because there are a lot of just sort of answers to questions in the latter part of the slides.
So when you're talking with patients about making a plan to vote or people that you work with, I think it's important to remember that there are registration deadlines. In Pennsylvania, it's 2 weeks before the general election. So you, at least even if you're unsure, the person you're working with is unsure about whether or not they want to vote, at least make sure they're registered. So in case they change their mind. Mail-in ballot request deadline, that's 1 week prior to the general election. However, you also need to make sure that there is enough time for the person to mail back their ballot. So it's received by the election office at 8 p.m. Talking to people about when do I vote, when are the polls open, what do I need to vote? You need an ID that first time you're gonna vote in the precinct that you're gonna vote in. Where do I vote, the polling place, how am I getting there? And then who am I going to vote for? Can't tell people who to vote for, but that is a barrier that people have encountered, is not having enough information. So we can point them in the right direction. Where can they get information about candidates? We're gonna skip through some of this stuff. We'll send all of that out.
I do want to just highlight one thing if we go back. So, one of the, criterion on that, Healthy Democracy website is about whether people who've been convicted of a felony can vote. So one good thing in Pennsylvania, is on the right side, those who have been previously convicted of a felony may vote. Those who are currently serving time in prison on misdemeanors can vote. Those on probation, parole, or house arrest are all eligible to vote, and many probably do not know that they can.
And then these are some suggested responses that we'll share. Some conversation starters in case you're wondering how to broach this with folks that you work with. The election is coming up. Do you have a plan to vote? Maybe the deadline for voter registration is October 21st, 2024. Are you registered? Or I just saw a presentation about mental health and voting, so now I'm asking everyone I work with, are they registered to vote?
Maybe you can add Ken's, you got a problem with
Yeah.
this?
Yeah.
Like that. Going forward, we're not gonna do this right now, but think about maybe one action step you personally can take moving forward to promote civic health among your patients. Our thank you slide, and then these are some helpful resources. Again, we'll send it out, but there's a lot on the Pennsylvania Department of State website. You can actually, that's where you can register to vote. You can request a mail-in ballot, and they also have a wonderful voting toolkit with like social media icons and graphics. It's really nice. They redid it this year. NAMI has a Vote for Mental Health campaign. We've partnered with Vote ER. They're all about point of contact, healthcare-based voter registration. National Voter Registration Day is past, but it happens once a year. So next September, the Temple University Collaborative has some really nice information on civic engagement in a recovery-oriented lens. Patient voting is all about voting for people who are inpatient. And then the Committee of 70 and Vote 411 are two places people can go to get information about candidates and also fill out mock ballots. I have to give a shout out to Val, who told me about the Committee of 70 mock ballot last year. Because that's another thing that can be real stressful for folks, going into that booth being like, oh my gosh, I have all these choices I don't know anything about. So if they really want to vote in person, they can prepare with a mock ballot, or they can, vote by mail at home. So thank you all for your participation.
You'll see the vote.
Yeah. When I said I did before the blue, I'm starting to walk up with it.
Oh, I like doing my mail-in.
The first thing I do is bring my bill off the press one. They go, oh, yes, so I don't have to go to your vote.
So then they'll ignore you.
That's one thing we do. We don't do. You guys need separate chambers. Yeah.
Making that.
Wondering if I can get this chair from over here.
Yeah. Great.
Do you want to introduce the panel? You have the clip?
Mary Ann introducing her. Mary
Well, we're back at it, so we have like a minute break and I'm changing things out. I'd like to welcome, everyone to the first panel discussion, how to advocate efficiently lessons from the field. And we have with us, Kathleen Doherty, who is a friend and colleague, from this area, who's worked in ethics and in forensics and, brings her knowledge to this panel of advocacy from her active work at the Pennsylvania Psychiatric Society on government relations, as well as friend and colleague Ken Serta, who hails from Philadelphia, and he introduced himself earlier. So I don't want to, without further ado, take it away with your presentation. We are missing Hope Solarnik today. She is ill and we miss her. We have slides that are a part of the materials that she would have shared and that might get discussed today. All right, take it away.
And so as I said previously, I'm Kathleen Doherty. I'm from Penn State Health. But nothing I'm saying today has any authorization from Penn State Health, and I am not representing them. I think that's an important point anyway, when you are going to be advocating for something, to make it clear who you are representing and who you are not representing. I feel a little bit like Kate also in terms of an imposter syndrome when Deb asked me to do this. Because I will tell you, I'm probably the most politically ignorant person you will ever meet. I'm famous among my friends for not knowing anybody who's running for any office or understanding what any of the offices are. And that has been much of my life. However, the three of us who are on this panel are all past presidents of the Pennsylvania Psychiatric Society. We are all members of the Government Relations Committee. Ken is currently a chair. I would past co-chair. And through my efforts in the society, I have needed to represent the society in a variety of governmental areas. And so I have had to become an advocate, which I did with great trepidation. I, however, am a person who is able to communicate well. I can speak well. I'm intelligent. I can convey a point. And in many areas, I'm a content specialist. And I'm like, holy crap, I can be an advocate. And I've been trying to do that. So we're actually, partly from my request, starting at a very ground level. Because I know when Ken has been putting out requests for people to do various kinds of meetings and advocacy, I have seen people be fearful about that. People say, I don't know how to do it. I don't know what I'm doing. I don't think I'm the right person to do it. So we're actually starting with that today. Now I'm hearing a lot of people here who are just way above where I am in terms of any political knowledge. Well, all of you are there, but maybe not where Ken is. But we really want everybody by the end of this to have a practical sense of what to do and how to call upon your various legislators at the end of this and talk to them effectively.
All right, well, let me just get started with a couple of things because we don't have a lot of time. But some of these slides will go by very quickly. This is us, with the exception of Hope, who I hope will recover quickly. Our disclosures, actually, there's an error there. I'm not the parliamentarian, I'm the parliamentarian of the board of the American Psychiatric Association, the board of trustees. And I am on the board of directors as Dr. Alba of the APA PAC, And we'll talk about PACs at some point. Some of you love them, some of you hate them. And also the Pennsylvania Psychiatric Society PAC. Kathy has nothing to disclose, and Hope was worried that she, as she must, as an employee of the VA, has to disclose that nothing is VA policy, but she is not here, so we have to worry. So efficiently, I wanted to put that in there because I mean, everyone has passion. I mean, everybody's here because they have passion, but we only have a certain amount of time and a certain amount of resources. So we need to make sure that what we're doing is getting where we want to go. And the one thing that I would encourage everyone to do is to be careful with your passion, because sometimes it can cause you to expend that time and resources inappropriately. You really have to think smart, because we all get busier and busier and busier, certainly now, very busy. And we have to make sure that we're doing the things that we need to do in the appropriate time. Speaking of time, we also speak about place. The handsomest building I ever saw, according to Theodore Roosevelt, when it was dedicated back in 1913. It's a great building, and you'll see more about it inside, but we're going to be focusing on Pennsylvania. I mean, there are other levels of advocacy, certainly lots of stuff going on in DC, much of which influences the different states, but we're going to really be talking about what we can deal with mainly, which is here in Pennsylvania. And that means we need to know about this place. These are all scenes from within that beautiful building. This is the governor's reception room. So we're going to talk about just the different levels of government. This represents the administration, the governor, OMSAS, Department of Human Services, Department of Health, all the other agencies in the administration, which is one area to advocate for. Probably not as easy in some ways to advocate because they are bound by what happens here. This is the House chamber. Spectacular building. Right, really. If you haven't been to the Capitol, you really should, just to take a look at what all of our tax money from 120 years ago went to. But the House is where most things get started. The House is the people's chamber. There are 203 folks there. And this is the Senate. Things move up to the Senate. But this is where you really need to be. This is my state senator, Maria Collette, and that's her district office. And I would encourage you, after seeing how beautiful the Capitol is, to work in your districts, because the districts are really where most of the work is done. It's easier. I mean, that district office is one exit away on the turnpike from where I live. 15 minutes to get there. I've been there several times. And she's a very nice woman. She's a nurse, has a lot of experience with healthcare. And this, not quite so grand, this little place here, that's his office. This is Greg Scott, who's my state rep. He represents 60,000 Pennsylvanians. Maria Collette represents 250,000 Pennsylvanians. So it's a lot easier to work with him than with her. Both nice people. I will not get into my impressions of the two of them, but she knows healthcare better than he, because I mean, he was a judge, but he is not as savvy about healthcare, which is great, because in many ways I can educate him. But you can't talk about politics without talking about politics. And these are the current issues, because it makes a huge difference as you're going to be an advocate. You have to pay attention. You have to know, love it, hate it. This is what we have to deal with. So I put this slide here, much to Kathy's consternation. And those of you who are on one, I mean, I would imagine that many people in this room are on the Democratic side of the political equation, just because we are in healthcare, we're bleeding heart liberals who want to have, you know, everything for everybody. We are not Republicans who want to be fiscally prudent. And these tend to be how the traditional parties' ideas line up. And you should know that mainly because that's how the parties tend to go. In general, if you're If you're a Democrat, you want big union, you want big government, mainly supported by unions and trial lawyers. For those of us who are physicians, trial lawyers are a little bit of a problem in many ways. And in general, the cities. This is who takes care of the cities. Whereas Republicans are much more rural. Pennsylvania is a very rural state. And so you have to pay attention to that because at any kind of policy we're trying to put forward, we have to take care of both. And actually right now, because access is such a big issue, this is ruling the show. People really need to make sure that we get enough people out there to take care of folks in the rural areas, like where we are, as was pointed out. And in general, the Republicans want to try to keep things down. They want to spend less money, make sure that programs are really working, as do Democrats, but Democrats, oh, there's more money coming. So, governor's chamber, you're the Democrat in control, which for many things is good for those of us who are concerned about social programs, but not everything. But we need to be aware that the administration is controlled by the Democrats. As is the House. First time in many years, in 12 years, the Pennsylvania House went over to the Democratic Party. And so all of this, the committee leadership's changed. The agenda is run by one vote. It's just one vote that separates Republicans and Democrats. And that's vitally important because we have an election coming up. There's no guarantee that it's going to stay in Democrat control. The Senate is in Republican control and will almost certainly stay there. And what that means is we have divided government. We're one of only 2 states in the country that has this kind of divided government. And we are constantly at work trying to figure out how to negotiate that because the politics are so important. How it's important is because of nothing can get done in a body of 203 members unless it gets broken down in committees. Even the Senate with only 50 members, you need to divide up into committees to try to get the work done. And this is just so important that it can't be overemphasized. Every bill gets assigned to a committee. The committee chairs are in charge. And the committee chairs are appointed by the party in charge. That is so important because, for example, if you have a bill that you really think should go through, and we'll get to exactly how bills become law, and it gets assigned, and it's sponsored by a Democrat, and it's introduced in the Senate, it's essentially dead because the Senate is controlled by the Republican Party, and they are not going to let the Democrats do much of anything. Now, I'm speaking with broad generalizations. Obviously, there are differences there, but if you want to get something done, you want to make sure that you're using the party in power to get it introduced. And so you have to know. So when I'm talking about working efficiently, it doesn't make a lot of sense to spend time advocating for a bill that's put into a chamber if it's put in by a member of the minority party. You can rant and rave and you can hope, but until you get some co-sponsors from the majority party, it's not going to go anywhere. So why waste your time? There's so many other things. Please don't waste your time on things that are tilting at windmills, as they used to say, when people used to read novels like Don Quixote. And the other thing that's important is that staff are the folks who are there from session to session to session. And even when the parties change, who's in power, the executive directors of the committees tend to stay on. And even though last session there was a Republican ED that was essentially managing the House parties of jurisdiction, committees of jurisdiction, and this year it's the Democratic side. They work together, they've known each other, they know who is and who wants to vote for what, where the issues are. So let me just go on to one last thing, because people have stuff to talk about. So look at this process. This is how we get from our wonderful idea, which we want to try to address. And first we have to figure out how it can be done. Is it something that legislation can even address? Because there are a lot of things that legislation can do and a lot of things that they can't. You want to find a sponsor, again, preferably from the majority party of the chamber you want to introduce it into, which is tricky right now because you want to find a Republican senator and a Democratic House member. And again, ideally you get a member of both parties. If you can't get a member of both parties to do sponsorship, you have to think carefully about whether it's worth the effort to go forward. Again, if you can't do even this, then what's the chance you're gonna be able to get through? There are some things where it can happen, especially if it's an issue that has some political saliency to it. I mean, gun legislation is probably the biggest one where if there's been a school shooting recently, things are gonna happen. How much is unclear, and in the current divided House, it's almost certainly divided legislature, it's probably not gonna happen at all, but this year, for the first time, because the Democrats are in control of the House, we had a red flag rule that got through the House of Representatives. It didn't go anywhere in the Senate and almost certainly will not, but the only thing that would make it move is if there's another big school shooting, just the realities of things. So what happens after you get an idea and you find a sponsor? That sponsor will put out a co-sponsorship memorandum. And all this stuff is available on the legislative website. We pay a lot of attention to this because this, and sometimes our friends, like all of you, will let us know, take a look at this. This is something that might happen. And you look and see if there's a co-sponsorship memorandum out there and what it says, what it intends to do. Sometimes things die here because somebody will put the co-sponsorship memorandum out there and will not get any co-sponsors. And they'll say, well, good idea, maybe next session. And by the way, we do have a 2-year session in the House, in the legislature here. So everything that's not passed within the next few weeks is going to die at the end of this year. Has to be reintroduced again, as it often is. But everything has to go over again. But look at the co-sponsorship memorandum and then look at who signs on as co-sponsors. I will tell you, this is important because when you see something like that, this is the time to get in touch with your representative and say, please don't co-sponsor it or please sponsor it. Because the number of co-sponsors and who they are and how powerful they are is a way that a bill begins to move, that begins to develop some degree of. I need my inhaler, I don't need that.
Have that, I keep prescribing you.
I have an inhaler right there. If you want to make sure that you so this is probably the biggest area where we begin to start our activity in the co-sponsorship memorandum. Co-sponsor, don't co-sponsor. I will tell you that there's an issue that we're very active with where my state senator was asked to co-sponsor a companion. It was a House bill. There was a companion bill in the Senate that Maria Collette was asked to co-sponsor. And when I asked her, please don't do this, that was it. She just didn't do it. It's not a big deal for them. I mean, they don't have to give extensive reasons why, but her name being there would have made a difference. Her name not being there makes a difference. And so that was a very useful phone call. It can be seem like a relatively minor thing, but just make sure that, and again, I think it goes without saying, but say it, please be a constituent when you're calling. If you're not a constituent, it's much, much easier for the office to ignore you. But if you're a constituent, it's hard for them to do. Because that's who's representing us. So after it's introduced, it gets assigned to a committee. This is an interesting thing. Some bills get assigned. I mean, in general, the bills that we are concerned about are health and human services, professional licensure, occasional. I mean, everything will eventually go through appropriations if there's somebody attached to it. Judiciary. There's some talk, as I think everybody here knows, about redoing the Mental Health Procedures Act. That's going to be assigned to the Judiciary Committee. So we are looking carefully about who is on that committee, who our members are in those districts to to try to influence those votes. The committee chair and the staff determine what will happen with that bill. Scheduling, I mean, a hearing, asking for information from interested stakeholders. We are often involved in either conversations or letters to the committee about areas of the bill that we're concerned about. We will sometimes prepare amendments for that. We, I mean, our government relations committee and all of you have organizations you work with, or you yourself might have some ideas about what kind of committee. It's tough to come at it just from the outside. I mean, there's currently a bill about the oversight of psychiatric clinics that's incredibly dense, that takes a little bit of time, and if you want to spend an hour at lunch, I can tell you all about it, but it's but there's some common sense things that you can take a look at and will make and you can take a stab at, but it should say this, and then other people who are a little bit more polished with the law can figure out how to make the amendment work. But here is where we again very much get involved. Voting out the committee to the floor, and that only happens if the chair calls for a vote. There are ways that the people in the committee can force the chair to vote something, but it rarely happens. Nobody wants to get their chair angry with them. And so if the chair wants it to move, it will move. If the chair doesn't want it to move, it won't. And the chair will generally only move it if it's the vote he knows is going to go the way he wants it to go. Otherwise, he will block. We often, things we don't like, we try to make sure that it doesn't leave the committee. Just because that's the easiest way to stop it, because the next step goes to the House chamber floor where anything can happen. At this point, it becomes much less the committee chair and much more what the leadership of the parties want. So at every step of the way, but especially here, we want to make sure that the leadership of the party in power is on our side. And if they're not, we want to know why not and see what we can do to amend it. Again, all of things in politics are horse trading, and we sometimes have to choose our battles. We don't want to get a committee chair angry with us because we oppose one thing when we're going to need them for something else. So we have to think clearly about what our overall strategy is. So in the chamber, it goes either up or down. And if it is that it gets sent to the other chamber, and there the same process happens. Right now, Democratic House, Republican Senate, anything the House wants, the Senate won't want, vice versa. So it's hard to get things done right now, unless there is some significant horse trading behind the scenes. And then if both chambers agree, then it gets sent to the governor for a signature or for a veto. One last slide. The details, where the devil always resides. Let's make sure that I'm going appropriately here. Yes, good. There are lots of things that can happen that won't happen unless there's money. A lot of you are familiar with the effort by Mike Schlossberg to get $100 million from mental health care several years ago. Interestingly, that happened because of school shootings. There were a lot of school shootings, and one of the things that the Republicans in power in Pennsylvania, because they controlled both houses at that point, wanted to make sure is that we don't do anything about guns when there are school shootings. And I mean, you can get into the politics of the gun debate ad nauseum, but basically, in order to make sure that nothing was done about gun control, let's throw $100 million at the mental health system. Great, fine, we'll take it. I mean, there are a lot of issues with that. It's not like our patients are really dangerous anyway and stuff with these negative stereotypes, but that money went through it. So that went into the budget. And then, unfortunately, even though that $100 million was in the budget, it had to be appropriated through the fiscal code. And this, oops, That wasn't me, I don't think, unless we're running out of time, as I read it. Just tell me to stop talking, I'll do it. All right. We're getting there. Last one, there we go. So. At this point, the money was taken. The governor decided that $100 million that's gonna go for mental health services, let's just use it for putting mental health counselor in every school. I guess that's okay, except it's not, because a lot of the things that we really fought hard to put in that bill just got wiped away, and we're still fighting over that. Because that it just didn't go anywhere because of the fiscal code. Another parallel thing in addition to the money is the regulations. And this is what was talked about earlier. Regulations really determine how things happen. There was a Act 65 that some of you may know some years ago that talked about changing the age at which adolescents could be committed to the hospital. Voluntary commitment, now parents can voluntarily commit them up to the age of 18. Used to be 14, now it's 18. And so there was supposed to be some provision for objecting adolescents to be able to do that. It was not defined which department was going to write those regulations. So that bill, even though it passed, sat there for years because no department had been defined to write the regulations. Finally, another act was passed to empower the, I'm forgetting which, I think Department of Health or Human Services to write those regulations, and finally went through, but that was held up for a long time because by design, no place was, because some of us really didn't like that bill, and we said, fine, the way to kill it, or at least delay its implementation, was not have a department. Are we out of time? Oh, sure, I'm sorry.
It's a fiscal code. I don't know what that is.
That is, that was news to me last year, to be honest with you. But it's the.
I can answer it.
You can answer it, please.
Yes, let's go.
Part of the budget process every year, there are a couple pieces of code legislation that go along with the General Appropriations Act. General Appropriations Act is essentially the bill that is the spending for the state fiscal year. If there are prescribing things within various departments, it is carried out through what's called a fiscal code. This is a separate piece of legislation that occurs each year. There are other code bills, the code bill, the tax code, those things might be familiar with hearing that. That's part of the process.
An easy way to think about it is it's the operating instructions for the budget.
Right, so it's.
And that's separate, the fiscal code is written by separate than like, here's like, I'm gonna introduce this thing. And then there's like a fiscal code is written by.
The fiscal code relates to the overall budget as distinct from an individual piece of legislation, per se.
I see.
So there are different ways. I mean, this can get fairly complicated, but a lot of stuff comes together in the budget, and the budget covers the whole breadth of state government. The fiscal code covers the whole breadth of state government.
But it's separate from approving the budget.
It's a separate vote. They go kind of hand in hand. So in other words, the money is appropriated in the General Appropriations Act. The fiscal code may say, of the 5 million appropriated for mental health, 5 million will go to crisis intervention, and the balance will go to counties or whatever, that kind of.
I think of it as kind of like the budget details, and it's where you can think money's going one place in the budget, but it ends up going someplace else.
Right.
It's a diamond.
Yes.
Yeah.
One at a time, please. There's a question in the back.
What's the writing then for these, not, I mean, genuinely, what's the point of writing them for these bills if the fiscal code is just gonna outline how things will be spent anyway?
Well, again, there are different types of legislation. We're talking about the budget here.
there's authorizing legislation that will set up a program that goes down a different track. And then the next decision will be whether they appropriate any money to implement the thing that you just passed. So there's a whole series of issues here, but there's authorizing legislation, and then there's appropriations or the Budget Act, where the money actually flows out. Probably the most important single policy-making document the state of is the budget. Where they put the money is where the action will occur. But the Mental Health Procedures Act, for example, of 1966, okay, think about how many things have changed since 1966. Okay, that's only been amended about 3 or 4 times in that whole intervening period. The discussion about reauthorizing or rewriting that would basically entail a whole series of policy decisions about mental health in the Commonwealth. Then there would be separate discussions about what you fund or don't fund under that act. How much money should go to counties? How much money should go to a variety of things? And I think Dr. Serta did a great job of laying out sort of a general thing. The only thing that I would add in terms of this level of detail is don't underestimate the importance of leadership in deciding what gets voted on, whether it's in committee or on the floor. So
Right.
the majority leader of the Senate, Senator Pittman, has a big say in what will come out of Health and Human Services or Judiciary or anything that you're advocating here. Same with the Speaker and the majority leader in the House. And leadership, and even there may be a majority in the committee that will support it. They may even vote it out of the committee, but if leadership doesn't want to get on the floor, it'll go on the table bill calendar and you won't see it again.
Ben,
Just really quickly, specifically having identified that leadership role, how do you have a communication with them or presumably their staff? Because they have they're in that leadership role, they're both sort of overseeing what's going on at the whole state level within the party and the proposals that they've got, and they're managing their own constituency. And the only people that they'll listen to theoretically are their own constituents. So how does that work? I mean, how do we do that part?
I'll get into that a little bit.
yeah, but what I've been told by Greg Scott, my rep, is that the Democrats caucus weekly, and issues that are brought by constituents can be raised at that meeting now. And he had the impression that Matt Bradford, who's the Democratic leader, the majority leader, listens and pays attention, and a lot of it is done through lobbyists, frankly. Our lobbyists have connections with a lot of the different committees, and we'll talk about just specifics about what we do, what lobbyists do, and so on. But I will recognize that we're running out of time. Thank you for the expertise coming from the corner of the room there. I appreciate it. But let's move on to what we can do without your level of expertise. Dr. Doherty, I will give you the floor. Yeah.
I want to start with the obvious part about it, which is think about what is it that you want to accomplish? And generally, we've got maybe 3 areas here. Are you trying to support a piece of legislation that is in process? Are you trying to oppose a piece of legislation that is in process? Or is there one that's not there that you want to get created? And I'll start with that last one, because Ken mentioned that takes a lot more work from the ground up, okay? And generally is something, everything starts with an individual, but may need to go from an individual to a group in order to actually come to fruition. And we are currently at the Pennsylvania Psychiatric Society, for example, looking for sponsors for funding for additional residency slots. And that is something that is coming from us. But we need to get out there and find, support for that, and maybe if we have enough time, we can talk about that a little more. You would think that supporting might be the easiest, because if you're contacting somebody who's already put out a bill, of course, you know, you want to say, yay, I like that, that's great, so your two minds are thinking alike, why even contact the person? Well, you are, if you have somebody who's already in favor of it, you may be able to be giving them some points to keep them in favor of it. Or some points that they can use in talking to people who are not in favor of it. You may also be looking to get people to co-sponsor the bill. And so the more support you can get, the better. So you may be reaching out to someone who's not currently a co-sponsor, but you're going to ask them to do that. Opposition, again, if it's somebody who has proposed the legislation, you are not probably going to be an effective person to go to them and say, I don't like it, take it back. So you're probably wasting your time there. But when you have people who are waffling about that, or they're not sure where they are, you may be able to help shape their opinion so that they will oppose it. But be aware that they may be leaning in favor of it, and you need to be diplomatic when you are presenting things so that you are not creating an enemy when you talk. So who is the person you should contact if you want to have a particular piece of legislation moved one way or another? Again, who is most receptive to your viewpoint? The sponsor of the bill is not likely to retract, so don't contact that person. But other committee members, if you know that the bill is in a particular committee, they may be willing to oppose. And so you want to address people who are in that committee, who would actually be able to touch that bill and who would be effective about it. As Ken said, majority, minority, parties are very important here.
One last one, just to interrupt about the sponsor of the bill. It is respectful to let that sponsor know that you are going to oppose it or that you have concerns, because every other member of that committee or every other person in that caucus will want to know, have you sponsored that? So you need to have dotted that I, crossed that T, just to let them know.
And also, if you're planning to amend a bill, you should contact the sponsor, even if the co-sponsor is not the sponsor. It's helpful so that they're not blindsided, because then they get mad at you.
Right, and often we're not opposed to a bill. We're not opposed to the concept of the bill, but the wording is very often off.
Yeah.
And we are suggesting either, and we have seen many times where there's an inadvertent wording in the bill that was not even considered, that would have very far-reaching consequences if it was left that way. And going back and reporting that, just and having to say, well, that's not what the bill says. And it's like, oh, yes, that's actually what the bill says. If you read it, can have people very willing to put an amendment in that. Remember, senior members have more clout than junior members. The chair of the committee has more clout than the committee members. That leadership people for the whole party have more. So how high up can you go? And who do you need to talk to? The legislator, him or herself, or an assistant? You have a better chance to talk to an assistant. There are more assistants for each person, and they're there all the time. The legislator will be between offices here and there and back up in wherever they're from and down in Harrisburg. Assistants can suggest items to the legislator to consider, and they do. However, going directly to the person who directly makes the decisions has its advantages. So if you can do that and get directly to the legislator, that's good. Timing may be an issue. Sometimes we have all the time in the world to talk to somebody, and sometimes you're hearing, hey, they're voting something out on Wednesday. What can you do today? And you need to move. And then you may not be able to talk to the legislator. So who should do the contacting? These are elected officials. One of the most important things to them is to be elected. Okay? Re-elected, and you cannot underemphasize the importance of that. Okay, in the end, being elected is critical to their career. So if you can't help elect them, your opinion may not matter. Can you vote for them? Are you in the voting area for them? Are you a constituent? And are you their party? Might be an issue. Okay, so all those Republicans that y'all think are important, let me tell you, they get to be important around this part of the area because they can go talk to the Republicans who are in office. If you can't vote for them, can you give them campaign money to get elected? And I know that feels a lot like buying an opinion, but campaigns are funded and they do look at where the money comes from. Okay? If you're not a constituent and you have an issue that you really want to have put forward, find somebody who is a constituent, help educate that person and get that person to go talk to the person. Okay? The more votes you get, the better. Are you speaking for yourself or are you speaking for a group? If you're speaking for a group, especially a group that can either give money or votes, make sure they know that you are speaking for a group that can give money or votes or influence. Because sometimes the influence for a future issue is important for them. And as far as representing a group or an individual, be very clear. If you work for an organization, but you are speaking as an individual, or you are speaking for another organization, make sure they know who you're representing and do not falsely hold out that you're representing multiple big areas when you're not. I did want to say sometimes going as a group can be helpful, like bringing several people, but that's not actually as important as representing a group. If you're going to bring a batch of people, plan it in advance. Who's going to say what? Because a lot of people repeating the same information just wastes their time and can dilute your message. So how best to interact? In person. Far and away, better than any other way. Meet with them. You call, you request an appointment. The appointment can be a variety of places. It can be their office. They're also happy to come out and meet you sometimes at your office. If you are part of an organization that is requesting them, you can ask them to come to your workplace. They love that. They love to make an in-person visit to whatever group that they're representing. Or go out for coffee with them. We don't normally think of that as, let's just go out and have a cup of coffee. I'll buy you a cup of coffee. I'd like to sit down and tell you what I'm thinking about. They enjoy that, actually. If your busy schedule does not allow you to commute, you can meet them in person via Zoom. And most people now have gotten much better about telling. That's one advantage about COVID. Okay. Phone call is down lower than in person. But it's hard to dodge a phone call. So if you're actually on a phone call with the legislator, they can't avoid listening to your opinion. They can avoid listening to your opinion if it's a letter or an email that's coming in. They can stack those up. They'll address them whenever. Usually those are read by assistants. The assistants may or may not pass them on. We've been told a handwritten letter actually carries more clout than a typed letter. I actually think that might depend on your penmanship, but that's. Typed letter versus email. Emails tend to be shorter. Letters are and give you more detail, but don't make them too long. 1 page if possible, 2 maximum, 1.5 probably would be better. And remember, letters sometimes have to go through security to be checked. So if you have a time crunch, a letter that's being held up to make sure it doesn't have anthrax in it, may take a while until it gets to them. Whereas an email will go in straight and be ignored, but an email will at least go there. Now, an email blitz, if you have 100 emails coming in, right before there's going to be a vote, that may be of some significance. But who doesn't? Okay, who actually can orchestrate that? That's often very.
No, you can't.
So what do you say? You've got that appointment, you're going to meet with them. First, plan, rehearse. Know what you're going to say before you get there. Outline it for yourself. Make a handout about what you are going to say and leave that handout at the end of the visit. It is a tangible reminder for them of what you said that they can refer back to. And if you get confused while you're in there and get intimidated and start to babble, at least there's a coherent thing that you're handling. Okay? We think scientifically. We think research, data, that's what will convince people. These people are not scientists. The vast majority of them are not scientists. That does not convince them. They are people interactors, and the human story is what matters to them. They like the stories, they like the personal touch, they want to hear how this impacted somebody's life. We're all told, the tyranny of the anecdote. The tyranny of the anecdote is what moves that. One person's story is very convincing. I was talking to one of my representatives and he was telling me a story about how this kid couldn't get treatment that he had heard from somebody else because there weren't enough psychiatrists. This was about the whole psychiatrist prescribing thing. And I told him about how people couldn't get therapy because there weren't enough therapists and and the psychologist was going to be prescribing, they weren't going to be doing therapy. That convinced him more than anything else. Okay? Just a minor, telling him about a patient who couldn't get in for 9 months to get neuropsych testing. Okay. For us, that would not be convincing. For them, that can be very moving. And to the last, what adds impact? Money. Support for their campaigns, contributions. Other support is votes or influence. Lobbyists know how to work the system. They have connections. They are familiar with the officials. They can help organize coalitions. They can trade influence. They are listened to. Okay? Political action committees have money and lobbyists. Money, lobbyists, great stuff. You all hear? Think about political action committees. You do not have to belong to an organization to contribute to its PAC. And if an organization is doing work that is important to you, you feel you can't pay the membership dues, think about supporting their PAC. It really is an area where your viewpoints can be magnified, but it does take money. And it's not tax deductible.
All right, well, we have 2 minutes left. And that's even without Dr. Solarnik being here. I mean, I guess I can quickly go through her slides because she spent a lot of time preparing them. But just quickly, and these are really just here to be thinking. I like that picture. Right, these are the things that are on the agenda of our organization now. Workforce shortage. I mean, I think pretty much everybody, maybe the exception of residency slots because that's a little psychiatry specific, but these are just data points to be able to use in your lobbying. Although they don't always like data, these are kind of high profile things that we would be useful, especially this business about.
I'm going to interrupt and say one thing when you have a conversation. Do try and make clear what is a psychiatrist, what a psychologist, if you're going to be talking about that,
Absolutely.
because they usually don't know that.
Yeah, I mean, and again, I know a lot of people in here are, most people are psychiatrists in here, or psychiatry trainees, but it is true that it is not, you would be surprised who doesn't know that distinction. My state senator, Tillman, who I went to see the very first lobbying visit, Princeton educated, Harvard educated lawyer, had no idea that there was a difference at all. Smart guy, had no idea. But in any case, that the fact that we have a lot of beds but don't have a lot of practitioners, there are a lot of beds lying fallow because there aren't enough nurses to staff them. I mean, it's just at every level, there aren't enough people in the workforce. So Dr. Slornick's very big on collaborative care, a way to leverage psychiatric expertise with primary care docs that's been put into place with lots of data behind it. And as Dr. Doherty said, they don't care about data, they just care about what works. But this is how lobbying can start. This is Wendy Thomas. This is Dr. Solarnik. I had to show you that so that you also, Dr. Solarnik, on the steps of the Capitol with when a bill to try to get money for collaborative care pushed forward. Residency slots is important to a lot of us. Trying to explain to anyone how residents are funded is mind-numbing, I will tell you. But it is the kind of thing that has happened. There are now 14 states that have been able to put forward some money where states will fund this. So we're trying to get Pennsylvania to do that.
So does that states don't fund, at this point, Pennsylvania doesn't provide any funding?
Pennsylvania
for
does not. New
psychiatry?
Jersey does,
Okay.
for example. It's that. One other thing about lobbying, many people in the legislature are concerned whether Pennsylvania is ahead of the game or behind the game. The fact that New Jersey did this before Pennsylvania did this makes a difference to some of the people in the legislature.
We do have some fund that come to the fellowships for the
Right.
people here.
Right.
That comes from the dish, which is the disproportionate share. And I'm not quite sure how the hell that actually operates either, but there is. And one of the things that we should probably be talking about.
Do you think everyone here knows what disproportionate share is?
Absolutely. I know that's what you go to bed reading about, because the problem is you never get all the way through it.
Yeah.
But I do want to make a point here that, and by the way, we have a few minutes, because it's at 12, we have next steps.
Okay,
And
good.
we are sort of in next steps.
All right.
One of the things that we should be pressing for is an increase in the number of public psychiatry fellows. And the capacity to make sure that there's a venue for people who want to continue in public service to have their capacities, clear capacities increased. So we need to add that to the agenda for the Psychiatric Society. But I think it's actually useful to make a small point here, which is part of the reason that we've created the Pennsylvania Psychiatric Leadership Council was because while it's really important for the Psychiatric Society to have its advocacy and do its thing, it's also really important that psychiatry and the world of advocates and families and consumers also have a role and a voice that is combined. Because the challenge is if it's just psychiatry presenting, it's very quickly taken as a sign that we're looking for our guild interests and that we're not going to go anywhere. And so in some ways, this conversation that we have here is about vetting and making a connection with the advocacy world of folks who are concerned about families, who are concerned about the actual consumer experience, who are concerned about the public health of the whole state. So that's just another reason to understand, or how to understand what the PPLC is in differentiation from the district branch of the APA. But having said that, we see the APA district branch as being a critical partner in this whole thing, and that's why we're really happy you guys are here.
For very many bills, we sign on to letters of support or opposition with multiple other professional societies, consumer societies, other areas, so the more people the more organizations you have signing on, the more influence you are indicating you have.
One other,
Well, I was just gonna, I'll let you go.
one I just was gonna finish with the slides that The opioid settlement money is something that we are
PPLC doesn't want.
interested in, but are concerned about, how it's being spent. There's a lot of money from opioid settlement that is mainly going to, through the counties. And then the one other thing that I should have mentioned in terms of how money gets appropriated, don't forget the counties. I mean, we were talking mainly about Harrisburg, but a lot of money in Pennsylvania, the way that Pennsylvania administers its mental health, budget is through a lot of appropriation to the counties. And the counties have a lot of, like Philadelphia County, the Department of Behavioral Health and CDH, they determine how money gets funded. Like, for example, the opioid settlement money in Philadelphia mainly is going to mobile methadone clinics, which is an interesting idea. It's a big deal. Should it be mobile? Should it be, I mean, where things get a little crazy is things like safe consumption sites, which our mayor has said, no, absolutely not, no way, over my dead body. And
Somebody else's dead body.
yes, walk from Kensington, you'll see a lot of dead bodies, unfortunately. But paying attention to how this money is spent, and I think this is what Dr. Duffy was saying, essentially, know what's going on, read it. Well, you can't read
I will
it.
tell you, you don't have to read everything. You already know more than they do. And that worried me, is that I would get asked a question that was really, really hard and I wouldn't know the answer to. You know, and I haven't been yet, I've not even been asked a difficult question yet. But if you get asked something that you don't know, it's like, that's a great question. I'm gonna get back to you and I'll send you that information.
All right, so
So it's 12:06, would be awesome to get through all those slides, starting late, I think we started at 11:10. I wanted to add my 2 cents regarding the residency slots and how we partner together. We do have a workforce shortage, and there's this major effort, and everyone cheers it, that we have the growth of medical schools. And in the state of Pennsylvania, we have a growth of medical schools. We are, it's both an amazing opportunity and perhaps a challenge at this point in time, that when we go through the residency, psychiatry residency match system, that we are 99 point something plus filled, which means that there's medical students that are now graduating past their 4th year. They've done hard work. They've amounted a terrible debt, and now they can't get into the residency of choice. And we have a greater and greater gap of those kinds of folks that are caught in this system. So I think that this is really an important area that we need to hammer home to all our legislative constituents. So starting at the very beginning of a bill and getting some folks to support that is amazing.
yeah, and as Kathy reminds me, 2 years ago, this legislature appropriated money for family medicine slots. And it was done really just in the budget.
So we have a precedent.
We have a precedent, but so there are many different ways of doing it. There was no bill introduced, nothing. It just got slipped in at the 11th hour of the budget. And we were hoping that would happen this year. It didn't. We're hoping to both introduce a bill and get it in the governor's budget agenda. The governor's budget comes out in January, and that's where we're hoping to have something like that put in, but we will see.
Doesn't Shapiro have a whole council right now on behavioral health
Some of them are in this
improvements?
room.
Dr. Kim is on that council, and so hopefully we are helping her take many notes around what is important for that council.
Well, this would be one of them, is to get the residency slots increased and also increase the amount of funding for public psychiatric fellowship.
Right. And not just. And nurses.
Okay, we want to see if Amy can talk.
I don't think
I was muted and then I unmuted. Can you hear me? I just was going to suggest if there's already a proposal that the council has already developed. You could send me that because there's an opportunity to send some feedback currently on workforce issues. And I can actually send those questions to this leadership group if you wanted to respond to some of the specific questions that they asked for input on recently. Now I can't hear you, I don't think, but I'm going to mute myself so that you can unmute and there'll be less feedback.
My question is to follow up and ask.
Yes.
The question would be, how, hi, I'm Rob, how do we, are there ways to find out what the council is doing, what their activities are, ways to interact with them as someone who's kind of not a member of the council? Yeah, sorry, that wasn't really good.
Is she here?
Yeah. Oh, is Chris Danello coming today? She was on the potential draft agenda. I'm not sure she's confirmed to come today at noon. She leads the Behavioral Health Council from the administrative side. I think that's a good question that's come up a couple of times. I think the question was, is there a way to find out more about what the BH Council is doing? Is that accurate? And there are currently two bodies that are involved. There's an advisory council and then a behavioral council. And I think that the information that's being, is Chris coming today? I'm not sure whoever was drafting the original, no. Okay.
No.
Sorry, thanks for responding. So I think that's a really great point, and I can follow up to see what information is going to be posted. They are taking certainly minutes, and the information is being transcribed within the meetings. So you're not the first person to ask that question, so I'm going to follow up to find out when that information will be made publicly available. There are certain agenda items that have come up concurrently, and just recently was on workforce issues. Actually, as what month are we in? It was September's topic, and I think more will be coming out within the next couple of months. The council's been meeting monthly over the past since December of 2023 and collecting information and sharing information, and then there will be I guess like a white paper potentially, or proposal recommendations, and that will be open for input, I believe is the process. Go ahead now.
And I can mention that a recent meeting that I was in, I think was the Medical Assistance Advisory Committee, Deputy Secretary Smith addressed this issue, and she noted that she's heard complaints about the lack of transparency, and she did ask the Commonwealth to make sure that that information is updated, because it's supposed to be there for right to know and other things. And she was told it's coming, but they were doing some other upgrades on Commonwealth websites, and that it's in the list.
Before in the rules of administration, there's this one now. A really good way to get involved in another way is the OMSOS Mental Health Planning Council, and they have committees on children, adults, and older adults. And they're open there. You can be a sunshine member, so you're not elected to the council, or you can be a full elected person, member, I guess. And so I think that's a really good way. And then you hear from OMSOS and people on the council in those committees as well. I just have found that more effective than.
So is that something that we can have a little blurb that can get out to everybody so that we understand how to be able to access that? Ken?
Just, obviously, we've got a bunch of moving pieces here with the council. There's an advisory commission at the governor's level. There's OMSOS. There's also the State Department of Health has a whole initiative around the state health improvement partnerships. We also have Medicaid, within the Department of Human Services. So the mental health world, and actually the health world, is deeply fragmented and deeply problematic in terms of, thinking about it in any kind of coherent way. And one of the challenges that we as advocates have been really thinking about is how to figure out how to bring these pieces more closely together, so that when the State Department of Health puts a huge effort into its health improvement plan, that in fact, actually Medicaid, OMSAS, and are in the mental health world are actually involved and engaged in that process. So the reason I mention that is that the challenge is that we think that we've got the tiger by the toe, and the truth is the tiger always has us.
Well, I think that, my experience, in, being a part of the Government Relations Committee, a few years ago when, and knowing that colleagues were a part of that Blue Ribbon Committee that worked many diligent hours to figure out how we could utilize that 100 million and provided that information. And for me, what it was a disrespect and an ignoring of the information. And so it speaks to that fragmentation, and people can do whatever. And it's very
Right.
disconcerting.
Right, I was on that
Don't
council.
give up, folks, because I mean, that's when we start getting discouraged and saying,
Correct.
well,
I was,
I'm not gonna do it.
I have to say, I was
Oh,
on that council. I was on that council. I'm not discouraged. I expect this. I also, I was one of the people who proposed that the governors continue to have a commission focusing on mental health, because it's very apparent that the need to readjust the whole industry had not kept pace, and we needed at the state level to have that process. I was not able to participate. I wasn't chosen to be on the council. So the further council, so the challenge of staying involved with that or connected to it, particularly with the lack of any sort of feedback from it, has been a distressing process, but it's not unexpected. So what we do is we just continue to find ways to persist. And maybe that's a useful point to say out of this. The work, Ken, you've been doing, Dr. Artie, the work you've been doing over these years, Marion, that you've done, is an extraordinary act of persistence. I would even call it radical persistence, that we are just continuing to hammer it. That's the same that I think that PPLC has to be, and the truth, and maybe that comes back to the earlier conversation, that democracy and the role of integrating people's ideas and moving forward just requires ongoing hope and persistence. And that's what this is all about.
And I think that that's spot on, and I appreciate the discussion this morning and your presentation about how we can stay active in it. And just in that last minute or two where I expressed my distress from 2 years ago. So how do we manage our internal intense feelings around things that are, where it takes patience? And so this is where that collaborative work helps to support each other in being able to stay hopeful and, back in the game and.
We're going to talk about that during the ICT.
All right. Other questions? I think we're good. It's 12:18.
We actually have some questions here.
Pardon?
I did have a question, but as a lobbyist, I learned your process and how difficult it is to get not only a bill introduced, but a bill to the finish line within the 2-year time period. I recall a time where things that you think should get done by March, don't think that makes sense. It took over 3 legislative sessions, 6 years or more, to get a piece of telemedicine advanced through to the finish line. But to put a little finer point on it, there's in a 2-year legislative session, there's about 4,500 bills that are introduced and maybe 200 acts. So it's a very low percentage of what actually makes it across the final finish line. And as Dr. Serta alluded to in the presentation, a bill that makes it through committee onto the calendar to the other chamber and makes it 2 of the 3 steps to completion. If you don't get that done in the legislative session, it goes back to the starting line
same as any other bill, so they don't pick up where they left off. So it creates a challenging environment to get legislation through, so the advocacy and the push, the visits, the lobbyists, the fundraising, all the things, plus the education and information is invaluable. It all goes sort of into the mix of trying to get something to the end of the line. I really just wanted to highlight sort of the little percentage of what actually makes it through to the governor so.
Thank you. Other value,
I was just going to a logistical point, lunch is in the hallway, so you can find your way out there, either out there or in there, whenever you're ready. So, sorry.
Oh,
we learned in this process. So good afternoon. I hope that everybody had a good lunch. Thanks for sticking around. So for the latter half of the program, we're going to get an update from some of our Centers of Excellence programs. And if we have any fellows who want to tell us how their experience is going, very low, those stakes, just getting to know you type situation. And then I believe we have a presentation from Avi, although I think we're confirming that. And then we're going to get an update from the Racial Justice Subcommittee. And then Ken Thompson is going to lead us through some ICT exercises, which I think we're all looking forward to. So with that said, I believe that Wes, UPMC is up first.
Why not, Wes? We want to turn the camera too.
Yeah. Thank you.
Okay.
Yeah, once you get up
Where
there,
do I
further, you'll be
stand?
on, you get up closer to the.
You can sit,
yeah.
The further back maybe.
Yeah, if you turn around, you're good. There you go.
Yeah, Lucy just moved you on the, oh, Lucy has you. You're good.
Perfect. Anyway, so this year we have a pretty full house at CPSP, and 3 of our fellows have joined us, but we have 6 fellows this year. Challenging in many ways, but a couple of our fellows are remote. We have one woman in Seattle and another fellow in Boston. So we're kind of figuring out how to make that work well. Adi was our first remote fellow last year. So far it seems to be working pretty well. I think it's always a little bit more difficult to engage people remotely and kind of getting them into the conversation. But anyway, that's going well. We have a really good group. And I think you've noticed that they have a lot to say. So that's been good. And we also have our leadership group is large this year. Mark Berger has joined us this year. And Sarah Lim and Amy Silversmith continue to be with us. Our group is a little bit large because people are somewhat uncertain about their future. And we're trying to figure out how our leadership will look in the years ahead. But that's our main issues. We're continuing to do our video seminars. We're working with PPLC leadership to help with that. And so it's really more of a PPLC product now that we're hosting. But that's been going well. And I think we've had some really good sessions with that. The only other thing I think is that we've been trying to build a little bit more flexibility into our curriculum. So we've scheduled a few more field trips this year and just kind of some flex time within the curriculums for people to get to topics that they enjoy. So that's our report. Thank you.
No resident?
Did anybody want to introduce themselves or talk about what they're interested in or?
I'm pretty shy.
Bring your friends with you.
Yeah.
Bring on guys.
Come with.
That was definitely, that's what he said.
So, I did change shirts, for those that are wondering. Yes, that happened. I couldn't do the collar, it's just too much. So I'm Isaiah, interested in, like homelessness mostly. Thinking about how to expand access to care. A lot of our homeless patients, the ones I think about a lot are like ones who are like quietly homeless.
And so they're not going to ERs, they're not going to hospitals, they're not ending up on anyone's radar. And of course, they're not costing the healthcare system enough dollars for me to like pitch to an insurance company that it will save me money to house them. And so thinking about how we can best serve those patients. And then doing a lot of work with Wes with Neighborhood Living Project, which is kind of a housing first model that we have for patients who've kind of been chronically homeless, who due to mental illness haven't been able to like engage with Section 8 or things like that successfully. And that's a really cool program. I see patients get better in that program. It makes sense because they're getting housing. It's not my Lexapro that's doing it. But I think that's kind of really unlocked a passion for me that I didn't know I had. So it's cool.
Just introducing, just anything you want to say.
Yeah, sure. So I already introduced myself. My name is Risha. I'm in the fellowship with my CN Rob. But in terms of my fellowship experience, I think I'm interested in going into consult liaison psychiatry, which I think is an area that really can be connected to public psychiatry to a pretty significant, extent. It's not necessarily in the sense that we have a lot of non-traditional models or that we're kind of seeing people in the community, but more in the sense that there's sort of this continuum of care that is often really lacking when we see people in the hospital setting and then try to connect them to services in the outpatient or in other settings. And so that's something I've just been interested in kind of thinking about. And, not only in terms of how do we actually implement those models or how do we kind of more directly engage these patients in clinical care, but also from an advocacy standpoint, how we sort of really create systems that allow for us to say, obtain reimbursement to help engage these patients a little bit better, like incorporate some interesting models like peer support and other engagement, like I talked about yesterday. So that was really a big factor for me in participating in the fellowship. As far as what I'm doing this year, in addition to a bunch of CL stuff, I'm working with Isaiah and Wes at Neighborhood Living Project as well. And there is a lot of overlap, I think, in the people that I see, say, in the psychiatric emergency department, and then with consults, and then in NLP. So I think that's been really interesting to see kind of how people often fall through the cracks of these systems and then get re-engaged through programs like NLP and then are sort of lost again. And how do we kind of maintain a better people for these people? That's something I'm kind of hoping to continue thinking about during the fellowship, both through this fellowship and through the fellowship to do next year. So I think that's more or less it.
I'm Rob, and so I'm also in the same program and also in my last year of residency here. Clinically, my main interest area is in addiction site dual diagnosis work, that kind of continuum, and so been able to do a lot during residency with that, and it kind of touches all aspects of our work. I'll also be working with NLP coming up, and then non-clinically or like paraclinically, I do what I put under whatever I manage to shove under the umbrella of system, like health systems work. So sometimes that's quality improvement projects, which I do a little bit of. Sometimes it's education, which I do a lot of, and a lot of times it's advocacy. And there are multiple people here who kind of mentored me in advocacy over the past couple of years. So thank you to all of you. That fellowship's been great so far. I especially like the kind of lessons from the field, where you have people who are working community psychiatry, community mental health, peers, advocates, psychiatrists, social workers, talking about their experiences, because that really it's so much different than just hearing about this thing that's out there, where you don't really connect with it or understand its importance or really how it actually works on a day-to-day basis. So it's been a great experience so far.
So two things just to say. The fellowship itself is a product of advocacy. And it was started by folks working with folks who were then trying to remember where Estelle was. Estelle Richmond was that was before she was there. She was in Philadelphia at CBH, which is the managed care organization that she started. And then she went to be Secretary of Human Services in the Rendell administration. And a bunch of folks who were engaged in doing family advocacy, people involved in this room, approached her about figuring out how we could get the money that I talked about before, the dish money, this disproportionate share money, to use that to fund a fellowship in public psychiatry. And that's what happened, and we got a couple of places around the state to do that, which is why you guys are standing in front of us, which is wonderful. The second thing is the NLP. That was created as a result of advocacy within a coalition. This is now probably in the mid-1990s. It's a long time ago. A coalition that was formed in Pittsburgh to address homelessness. And we had to specifically pursue HUD funding in order to allow us, because there was a period of time when HUD was funding both the concrete, provision of housing, as well as human services to support that. So we got the money from HUD through advocacy or efforts to make that money available for us, and managed to get UPMC to pursue it, which was extraordinarily challenging thing to make happen. And we ended up getting, it's got to be in the $50 million of actual funding for housing over the last 30 years.
So I am the northern part of the UPMC Psychiatry Fellowship Program, the rural component. I've had the opportunity this year to work with Kirsten Taylor, whom you've met previously. She's home now with her little infant, so she delivered this summer and is taking some time off. She has a plan that she's worked out with her employer, so we're happy to partner with the UPMC Safe Harbor Behavioral Health System in Erie, and they're going to support her for a second year of fellowship. And she's been working with first episode psychosis, and in particular looking at psychosis and cannabis and their relationship. So having some opportunities to work with Dr. Bennett out of the University of Maryland, and just thinking about sort of next steps for her project. And had the opportunity to work with Clarice Dixon. Dr. Dixon is an early career psychiatrist, a graduate of the general residency program at Lecom Mill Creek Community Hospital. And I have a positive relationship working with Dr. McCarthy there, who is a graduate of the fellowship program. And so there's a number of efforts that we're going to try to continue to move forward with. And I'll let Dr. Dixon share what she's been working on. We do have someone in the pipeline coming up. Again, a really wonderful partnership with the Safe Harbor program, as well as Deerfield Behavioral Health, that supports the employment for Dr. Dixon, as well as her 4 hours of protected time each week in the fellowship. So that's how we work it. We're on the model of the Columbia University model, and we're always looking for folks that have a rural perspective and outreach, and that would like to partner. And it's really a wonderful opportunity for the program as well as the fellow in that process of their education in the fellowship, and perhaps that workforce and employment into the future. So I think about Dr. John Samora and Dr. Anthony Samora, brothers that went through that project, and again, partnered with folks in our universe. So I'll let you.
Hello, everyone again. So I have been working on fellowship with Dr. Abel for about a year now. I'm closing out on my fellowship. In the meantime, I've been working as an attending at a few different places that I've mentioned. Sarah Reed's Children's Center, Erie County Prison, and Gage House, which is dual diagnosis drug and alcohol treatment facility. My heart is in the community for mental health. I would rather work there than anywhere else. My project is actually about expanding access to care. I was able to piggyback onto Dr. Cindy Cho's from UPMC. She has a project where she's actually a psychiatric consultant for an integrated care clinic, and she's been seeing patients as a psychiatric consultant, you know, via the PCP. And she gathered all this data, but so she's, you know, on the population-based part, on the team-based part, but the measurement and the outcome part maybe wasn't there. So I'm helping her to gather some data from survey participants about their perspective on how their outcomes and their treatment went with the integrated care approach.
Hi, everyone. My name is Ashley Ahn. I am the former Associate Director of the Fellowship, currently the Interim Director, following Rachel Kelly's job. We unfortunately were not able to recruit any fellows last year, so no fellows currently. I do have 3 excellent residents from Penn with me, though. Thank you for coming. And focusing currently on recruitment, Dr. Kelly and I had created a PGY4 track, which was approved by the department, but was on hold, or is on hold temporarily as leadership transitions, and also just due to the things like excellent residents who we were hoping to recruit, who also department wanted to be chiefs. So a bit of like conflicting interests there. But yeah, so working on recruitment, both fellows for incoming years as well as a new program director. And then taking some time to like strengthen existing relationships and maintaining those as well. Yeah, so thank you.
Yep. Should have chosen an easier exit. Exit row seat. Sure requested that. Hello again, everyone. So at Penn State, our model is a little bit differently as we've transitioned in the last couple of years to a community psych residency track that's going through all 4 years of residency. We are currently in our 2nd year of that track. So we have current PGY2, Harvey Marshad, who started last year and is ongoing in that track. And then we have our new PGY1, Aoife Samar, who just started with us several months ago in that track. I think one of the exciting things for Penn State, thinking back to Ken Serta and Kathy Doherty's advocacy session, is that we actually created these additional residency slots. So this is 1 additional resident every year that Penn State is training and eventually adding to the workforce. And we did that by partnering with Cumberland County, which is the county just across the Susquehanna River from Harrisburg. It has also enabled us to place residents for training in that county. And that county has been struggling with departures and retirements of psychiatric providers there. So that's been a really nice partnership ongoing. We are also exploring sort of further sustainability of that funding model with Capital Area Behavioral Health Collaborative, which is the organization that administers the Medicaid behavioral health benefits for the 5-county region of Dauphin, Cumberland, Perry, Lancaster, and Lebanon. And so we're hoping to sort of cement that partnership and move forward with that. Otherwise, just sort of looking to strengthen and develop relationships in terms of community psychiatry experiences, elective experiences for our community track residents as they move into their 3rd and 4th years. And so just working on building relationships there. So I think that's it.
Thank you to all our COEs. Happy. All right, so I believe now we have a presentation from Abby, who is with UPMC. But we did not introduce him, but we'll let him introduce himself and talk to you a little bit about his personal journey with advocacy.
Thank you so much. I hope you can hear me. Sorry, I was not able to be there today. I am here at Orlando. My wife is attending a conference, so kind of I came with her. Thanks so much for giving me a chance to discuss my current work in advocacy and also kind of giving an update. I am Abhishek Netrukar. I am a child and adolescent psychiatrist. I am currently working at Keystone Health, which is a FQHC in South Central Pennsylvania. First of all, I want to start with taking a moment to acknowledge the incredible support I received from the Public Service Psychiatry Fellowship under Dr. Sawyers, and I am the first virtual fellow to attend the fellowship. I think that was really, I mean, I appreciate kind of me being able to attend the fellowship virtually. I kind of wanted to learn more about advocacy, more about community health and systems. And this really gave me a great opportunity, and their guidance and encouragement kind of helped me a lot. In terms of advocacy, I mean, every physician is really involved in advocacy, which involves like advocating for patients, directly, indirectly, advocating with systems like insurances, like for prior authorizations, for getting services, medications, accommodations at work and school. But there is also advocacy, which is kind of beyond direct patient care, which is also very important as well. We as mental health professionals bring wealth of experience that we can share with primary care physicians, various health systems, schools, and kind of wider. And we can also take wider initiatives, which can really make a difference. So I am involved at advocacy at different levels. So I'll start with the advocacy at the county level, wherein I got an opportunity to join the county mental health, intellectual and developmental disabilities and early intervention advisory board, wherein I work in partnership with the community to develop and assure the availability of quality services and supports for individuals and families. It provides a great platform for collaboration with community and county officials to develop initiatives that address local mental health needs for funding and resources, and also promote awareness for mental health issues. Wherein I'm able to review and evaluate needs, services, project facilities with the local health officials, and also kind of review the performance of the programs, make recommendations for the community. And recently I was also elected as the vice chair of the board. So I really found it a great platform, a great chance to advocate at the county level. Along with that, I am also thankful for the leadership at my health center for giving me a chance to get involved in the advocacy committee, and also later as a director of health advocacy. I would like to take a moment to stress the importance of the community health centers. The health centers provide comprehensive care to about 32.5 million patients, and that's about 16,000 service delivery sites in every state and territory. And they save more than $24 billion annually in reduced emergency, hospital, and specialty care needs. And they are extremely essential like for the community, and they need advocacy to thrive and kind of help. So I am glad to have been involved as part of the advocacy. So to get further training in advocacy, I joined the advocacy leadership program at the NACHC, National Association of Community Health Centers, who I have been closely involved with in advocacy. It is a virtual skill building program that provides experiential training, resources, and hands-on experience for emerging leaders to build advocacy engagement within the health centers and communities. So I really got a chance to closely work with community health centers all around the country. And also be part of their task force and be part of their advocacy initiatives, wherein kind of work on building health centers, advocacy network, and work strategically and collaboratively to identify health disparities and kind of work on how to improve patient outcomes. Along with that, I am also actively involved in various professional organizations as part of the I am actually also involved in the American Psychiatric Association, wherein I am part of the Pennsylvania Psychiatry Society Workforce Shortage Task Force, wherein I work closely with Dr. Selarnik, Dr. Serta, Dr. Alba. So the mission is to assess the psychiatric workforce shortages in Pennsylvania and recommend practical approaches to address the issue. I'm also part of the I'm the early career representative of the Central Chapter and also the education chair. So I get to advocate at the Central Chapter level as well. I'm also part of the Rural Psychiatry Committee at the ACAP. So there I am able to work with the ACAP initiatives on a national level in the rural psychiatry. Along with that, I have also joined I'm also part of the Emergency Department Overcrowding Task Force from Pennsylvania Medical Society, wherein we discuss factors contributing to overcrowding in emergency departments and raise potential solutions, wherein we intend to create a report for distribution to General Assembly, Governor's Office, and public. So, so with all these platforms, I find that I get to discuss with different people from different community. I get to participate in advocacy at local, state, and federal. So that really gives me a great picture, and I feel like I'm able to contribute at so much levels. So I would strongly encourage students, residents, and fellows to be actively involved in advocacy efforts. So if anybody needs any help, or I would be very happy to discuss with them how to involve in advocacy. So thank you so much. PPLC has been a great group for me. They have been very supportive and kind of helped me along the way in journey always. So thank you.
Avi, thank you so much. So Avi's volunteering himself if you guys need help getting involved. They can take you up on that, Avi?
Yeah, definitely they can. Yes. Thank you.
So just a really nice highlight of different ways where if you want to get engaged, there are definitely opportunities out there to do that. I'm sure there's lots of people in this room who would like to help direct you into those spaces if you're not already engaged. I'm now going to turn it over to Crystal and Marianne and Sierra to talk a little bit more about the Racial Justice Learning Collaborative and the Roundtable.
No, just tell me what to speak and I'll speak.
Yeah, we did. See how we're so organized.
Are you gonna change the?
The clicker should be up there.
Oh, yeah, you have it. I have it. You have it.
All right, well,
The name's not up there.
no, it isn't.
Silent partner.
Yes, okay. So, our job today is really to just get everyone up to speed with a project that really has been in evolution since, 2020. We started to meet, under Ken Thompson's leadership in 2020 February, when COVID struck, and we had previously been meeting a couple times a year, so in person, but not having that other kind of infrastructure.
So this was a new infrastructure that came about, and we started to meet weekly around COVID and learning from some of our partners who were working in MCOs and having state-of-the-art front messaging for us. And it really was quite an enriching experience at the time when all of us were fairly isolated and helped to support us. So the theme was COVID, and we met weekly. And then in May of 2020, we had the murder of George Floyd. And we stopped and paused and really spent time to try to understand what might we do as a group, and not just think about it or talk about it, but was there something that was actionable? And so we opted to look at our structure at the time. We were meeting virtually. Could we go to every other week? We dedicate some time to COVID, and alternative weeks we would work on what could we do that was actionable. And we had wonderful input looking at, I'm gonna come about to what Ken Serta was saying this morning. How could we efficiently, with the volunteer hours that we had from all of us and our bandwidth, what could we do that could get started that wasn't overwhelming? There is still work to do. I guess that's what I will put the promo in for. Stay tuned. But so we determined that there was a need in recruitment and retention pipeline themes for those of Black and Brown self-identified persons entering or in residency in psychiatry. That when you look at the numbers, what does the community look like that we have, and the numbers of those that we have in our workforce. So in psychiatry workforce, I think at the time we were looking at 2.9% that were African-American or identified as Black and Brown. And our community systems were at least 15% plus. And so this discrepancy was the most in this particular area, and we felt strongly that that's where we needed to land. There was wonderful discussion around Latinx populations, around LGBTQ, what could we do? But it seemed that as we were marching forward with our thinking about Floyd, that was what it helped us determine where we were going. So we looked at training and education and curriculum as one work group. What could we do there? And looked at recruitment and retention. And I'm in charge of this. Okay. So we had these work groups, and so we already had Thursday night covered. We had to find another time, a space and time. And so we started to look at additional meetings, and Crystal was one of the chairs along with, now, was it Stan or Deb? I'm trying to think. Deb. Okay. And then we had the work group for recruitment and retention. Stan was a part of that too, and myself. And we had a lot of wonderful participants that really enriched the discussion over time, meeting every week to figure out what we could do that was actionable. What we looked at was how could we develop a process for developing and sustaining an environment in Pennsylvania that help to support underrepresented Black and Brown residents in psychiatry in the state of Pennsylvania. We looked at a partnership. In that group, we had representation of folks from the PPLC, but those that wore dual hats for the Pennsylvania Psychiatric Society. So we had that richness in their voices. Then we determined that we really wanted to not move forward in spaces that we didn't understand. So we needed to understand better what were the themes, what were the concerns, what were the challenges. And that led us to a roundtable. And we asked it was kind of a parallel track. We enlisted the program directors as well as department chairs from the various psychiatric residency programs in Pennsylvania to partner with us. Could we get the word out to those residents that identified in this group? And would we be able to enlist them in a safe space where they could speak openly about what were the things that were working well for them in their life journey through this process and pipeline, and what wasn't working? What were the challenges? And so as part of that, we had a group that was then led by Rachel Talley and Dr. Sosamulu Shriyanka and Leon Cushenberry. And they were willing to be the facilitators of this dialogue. We worked long and hard. Eileen Diaz and joined in this process of how did we, what were the kinds of questions? What were we going to query? What were the themes that we wanted to know more about? As we developed that, we enlisted that time and space for meeting with this group in January. And Sierra McNeil was able to join that as sort of that silent scribe person that could capture this information. And I can't stress, this was for me a very important learning curve from May, June, July of 2020 through January of 2021, voices that share the importance of a safe environment. How are we going to make sure that these residents would be able to talk about the things that they needed to talk about and still exist in their residency program safely without retribution of any sort? And how are we going to protect that information yet be able to use that? So that there was a lot of dynamic discussion around that. We talked about valuing their time. So we've introduced Neil for their time to participate in the roundtable, and that happened in January of 2021. Wonderful, rich material, which we're not going to talk about today, but keep talking about the timeline. We got that information, and Dave Dinich, Deb Shoemaker had lots of conversations with the program directors, partner chairs, to enlist them not only in helping us identify residents, but also would they step into a space to say, I will meet once a month and have this kind of learning collaborative conversation. And 13 residency programs did that at the time, which was amazing. And we began to have them meet. It was the third Wednesday at 3 p.m., 4 p.m. of every month, with the exception of a few buys each year. So we've been supporting their meeting since March of 2021, and they continue to meet. So we just had our most recent meeting in September, and it's been really awesome to see the building of trust in that group. We are experiencing some growing and changing pains in that process. So we now have 17 residency programs in the state of Pennsylvania. Looking at how do we integrate those new teams. We've also had some transitions of leadership, and I know we have Dr. Gray on today from Einstein, and she's been a wonderful recruit to this process, but we've had a change in some of the leaderships. And so I think the group is going to have some growing and developing around a new level of trust in terms of where they're at and what they talk about in the themes. Okay. So there's a number of wins that I wanted to share. So in the midst of this, we've had regular roundtable meetings quarterly that Sierra continues to support. They are supported with a meal. And the challenges for us have been in logistics about how do you make sure you're capturing as many and all that would like to participate. And we have a transition every year, so we've had graduations and we've got new people coming in, and so finding our way with that process has been an important one. In April of this past year, we had our very first annual, hopefully annual, Pennsylvania Psychiatry Residency Fair to really highlight some of these welcoming efforts that all of them are doing to bring psychiatry residents and those who are underrepresented to Pennsylvania for training and hopefully to stay after training. We are looking at, we've got it halfway done, and I don't want to steal your thunder, so I'll let Sierra talk more about the in-person efforts. We've got the Learning Collaborative very much wants to move to additional underrepresented groups, and in particular the Latinx group. And so we've had some preliminary meetings with our Hector Colon Rivera, and Dr. Ortiz has helped to organize those, and I'm gonna forget the person out of Philadelphia. Thank you, Dr. Ortiz out of Philadelphia has been a part of those conversations to look at what might be the ingredients to see what those needs of those residents are, that we don't want to presume what we don't know. So we're exploring that. We are now looking to, Crystal will share more about the training and education and library experience. We do have a resource library that anybody is welcome to, so we can make sure that you have the link to that. We've had successes in spreading the word. Rachel Talley and I were able to do grand rounds with the University of Washington. They were very interested in this. It was this project was highlighted in the Psychiatric News. And we've also had Leon Cushenberry and Dr. Serta share that with one of the residency programs in their grand rounds, and that was early on. They recognized that they might have an institutional challenge or pushback around some of the efforts at diversity, equity, and inclusion, belonging. So they were able to do a grand rounds there. We've had the opportunity to present at the APA Mental Health Services back in 2023, and Dr. Diaz, Eileen has been able to take our poster to both that Mental Health Services Conference and the Association of Academic Psychiatry, and work at pushing some of this information out into publications. So, let's see. We're working on two roundtable initiatives. One is to look at those that have been alumni, that have kind of worked through this process and been participants in the quarterly meetings, to come back together and help us understand what's worked and what hasn't worked, what are their ideas for change or development, and to query the current resident group in January around similar things. And with that, then I'll finish up. We have been recipients of the Assembly's District Branch Best Practice Award back in 2022 for this effort, and the Annapolis Coalition Innovation Award recipient as well. So it's been a wonderful journey that we want to keep on moving with, and that's on my slides.
I'll go down for you.
If you want.
Okay.
I'll probably have it shorter.
Okay, go ahead.
There probably won't be any questions from me.
Okay.
So, as Mary, I mentioned in the beginning, we had two subcommittees, and we knew at some point, even from the beginning, that we would be merging them at some point. But we wanted to stay focused on specific tasks. So part of my group was the curriculum and education piece. And what we looked at initially was, well, we looked at a lot of things. My committee was very
outspoken. Which was nice. It wasn't bad. It kept us, keeping them on track, then it was a whole other, that was a whole other piece, but, some really good, discussions were had. So one of the places, other than how do we involve the community, or better yet, how do we make sure the residents are involved in the community? Like, how do we bring those two together? So, and that's still under discussion. But initially that was a big piece. The other one was, how do we provide, not, information to all residents on, particularly around, people of color? Like, what do they need to know in order to provide good service? Because we realized we didn't have enough psychiatrists of color or residents of color to be able to do that. Logically, so it was like, so what do we need to provide for all the other residents? So we created it at the time, it was really, it took a while, it took a long while, put together a list. So everybody was recommending literature, reading material. And at that time, we had someone on our committee from, say, Temple, a psychologist, and she put her interns to work in catalog. Oh my God, it was beautiful. It was enough to bring you to tears. But it really was from that focus. We were not focused on, that anyone from Kelly needed to know, although they might be, but that was not our focus. How do we bring everybody else up to date? And make sure they were, and of course, my concern has always been, how are they providing quality services to anybody that they're working, no matter where they're from? So that was a big part of it. And then we also looked at, we brought the group together several times to talk about what does their curriculums look like? What should they look like? What would they need to look at? And UPMC, Mike Travis had some residents who started putting together what would 4 years of this look like? How do you integrate it in already existing curriculum, or do you integrate this information in everything they already? No matter what you're talking about, these issues are integrated. So that was some long discussions. And then the residents who developed this curriculum for UPMC came back and they did a presentation for the whole group on what it is they were doing, what would be presented in year 1, year 2, year 3. So we are now looking at the end of, they'll finish year 4, right? So that's starting. So we're hoping to get some feedback on what that looked like. And we're hoping Mike will be able to do that. Of course, we didn't ask him yet, so no one knows. So we'll pretend, but so that, and then at that point, we started meeting more as a group, as the focus became much more across the board, and how, because it's all interconnected work. But once the big heavy lifts were off, then we were like, and also realizing there's only so much, because we're meeting every Monday now instead of every other Monday, and we're also meeting every other Thursday. So, but anyone who would like to join us, please let us know. Yes. If you have any questions, please ask. And no.
Now I have the floor.
Now you have the floor.
So yes, as mentioned, I am running the meetings for the residency collective. We're in the middle of name change. We haven't completely changed it yet. But we know that the ending is going to be residency collective. We're just not sure what the first part of that is going to be. So when I first got involved with this, I just felt that it was me running the meetings logistically for the residency collective. However, as I begin to, I try not to sit in and listen on the conversation, but every now and again, there are certain keywords that pop up that I do listen to, just to make sure that, if there are any questions that I can answer, to answer on the call, but also help me think through how else can I support this group. I do not want this group to be a work group, but I do look at sort of how else can we support this group. And so a couple things have happened that I find actually pretty fascinating. So the first, well, this is not that much fascinating, the other stuff are, but the first thing is that we had in-person events. And so I think this is pretty huge. We have been looking, the residents have been asking for a while of, that in-person connection. I think we are all still living with Zoom fatigue and sort of missing that in person. And so we had an event at Top Golf here in Philadelphia. And so that was very successful. I did try to plan one out on the West Coast, but I learned that, some residents are not always reading my emails. I'm not gonna say who, in this room. But no, it's okay. I get it. Some of my emails can be pretty lengthy because I'd like to send maybe one, so then that way you get everything in there rather than me sending multiple, but it's okay. See you. But I will say, so we had the in-person meeting. I'm gonna try again. I also think it was timing. My schedule doesn't always match up with the resident schedule. And so the one that we had in Philadelphia was in June. The one I was trying to plan on the West Coast was in August. And I realized that the summer may not be the best time for residents in-person events. So I'm gonna be looking at the springtime. So March will be on the western side of the state. And that's just because it aligns with my schedule. I know I just said that, but I'm looking at March for the western side of the state and then maybe May for the eastern side of the state. The other couple things that come out of this is I'm learning more about sort of what it means to be a resident. I am a social worker, I am not a resident, and so my understanding of residents and psychiatry honestly come from a place of a little bit of enviness because I'm like, what do you mean you have problems? Like social workers out here, we're really dealing with problems. But then as I began to really understand psychiatry and residents, I realized that we're also dealing with some of the same struggles. And so really looking at how to support, and this led me to understand that there's not much support for residents in terms of we're asking them to volunteer and take advantage of these amazing opportunities. Like we had one resident who got selected to go to Africa and provide services out there, but they are expected to fund that entire trip. And I think this is a problem. And as I was doing research, I found that there's no funding for this. And so how do we expect someone to give up not only their time, but then also expect them to fund something like that? And so that's making me think, what else could I possibly do to support this group? The other piece of this, and this actually came from Dr. Shuenga, he's actually my mentor, so we meet. And then also Dr. Wills came to one of the residents meeting to sort of talk to the residents. And something that came up was this idea of mentorship. And that how she and both Dr. Shuenga expressed that part of why they are in the positions that they're in is because of mentors. And I know that I deal with this myself and also with social workers, that how do you find a mentor? How do you build that rapport? How do you find time to, meet with that mentor? So this is something that I'm also looking at exploring to see how we can provide mentorship to the residents. The last piece is that Marianne had mentioned that we had a residency fair for medical students. We had one bright, intelligent medical student that reached out to us and was able to sort of help us understand what we did right and what we could improve on. But I stayed in contact with that medical student and she's helping me think through how to look at residency and recruitment and retention as a spectrum. I have noticed that when we talk about recruitment and retention, we usually start when we need someone. We don't start before that. And so there has been a lot of conversations around community engagement. There has been a lot of conversations around, medical students. And so how are we sort of bridging the gaps and creating a pathway or a pipeline, whatever language you want to use, to really help with recruitment and retention? And the last piece I'm going to mention is that I did have one hospital reach out to me, a program director, because they had 0 new residents from underrepresented groups. I hope I said that correctly. I believe they had 0. And so that program director was like, this is not just a recruitment issue. This goes beyond this. This is not just like a bad luck that these residents went somewhere else. What else could we be doing? And so the first question I asked is, one, where are you recruiting? So what fairs are you going to? And then the other part is, what does your community engagement look like? From my experience, if I'm looking for a job or I'm looking to go to work with someone, if I look at your entire company and there's no engagement with the community, there's no engagement with my community, and there's no staff there that looks like me, why would I come and work for you? Why would I want to be involved in your agency? And so I'm happy to say that this program director really took that conversation and has made some huge strides. She got a position created. It's called a Chief Community Outreach position. So this is going to be supported by a resident. I also said that if you're going to put a resident in this position, that you need to make some flexibility for them, because that is an extra task, and I do not believe in overloading residents with more work. And so I do think that they took that into consideration. So overall, what started out as just an opportunity for us to create a group of residents coming together and sort of use this as a therapeutic opportunity to connect with other residents across the state has now branched out to really looking at not only how to support residents, but program directors, but now also possibly medical students. That is something down the road, because I will say it is just me. I wish I could clone myself or had someone else, but I'm excited for the future of the residency collective and what comes out of it.
And I think, thank you both. I wrote the word intentionality and I heard Leon Cushenberry's voice in my head, because he really has been a mentor for me in my learning of this process and how to, that engagement. And I think of some other folks that we've had in our group that have really been wonderful in the way in which they've partnered to move this forward. I will echo what Crystal says. Any of you that are interested in joining our effort Monday nights at 6 p.m., you are more than welcome to. Lucy Ann will get you the link, and we'll get you up to speed with how to participate. I think that the residency programs themselves are very much interested in how they also help in that longer term view around faculty. And so faculty development is another area with those that they already have, and making sure that they are well supported with tools and understanding to support the residents in a meaningful way, with cultural sensitivity and being able to work in communities, and then to expand what that group looks like in their diversity.
I think I just want to add one last thing. I should have led with this, but when we talk about peer-led groups and the importance of them, sometimes it doesn't always get the recognition that it deserves. But I was talking to one resident, and they were able to share with me that if we didn't have this roundtable or this residency collective in place, they don't know if they would have been able to finish their residency. And so that is the importance of a group like this, that connection, like they were talking about sort of how they now have friends and they were able to connect. And so this group is a lot more than just, numbers and, all of that. This is really changing people's lives, like the impact that that can have on someone, that they're like, now I can actually finish my residency program. Those are sort of the things that are not always at the forefront of this work that we're doing. And so I just want to put it out there that this is actually changing people's lives. And so I'm really happy to be a part of it.
And that's been, I think about Stan and Lloyd and others in the collective of planning and thinking through and measurement, how do we measure success? There's data, but then there's this qualitative stuff that is really important, and how to capture that.
Yeah, one of the things that this collaborative group can provide is, we actually, and many of, I don't know whether the directors even, the training directors even, there are measurements for have things changed, are they better? Is it going in the right direction? They will make sure that in the group that, that Sierra is facilitating and not share with the program. And I understand the reasons for that. I don't know that the county's done that with either, but it is a way for us to start gauging how we made a difference, from, especially, happening from the very beginning, thinking about curriculum and training and education, what that looks like. Yes.
It's a challenge to be disciplined about this, but it would be really good to capture, the success stories. And the kind of thing that you're just describing is a kind of example of a success story. And that's actually hard data.
Yeah.
It's hard experiential data, and I don't want to downplay it. It's important because it is people in the end who make this all happen, and what's important to people is what counts.
Yeah. That same resident has helped me figure out how to make what like a quarterly scholarly update, because I'm also learning that a lot of our residents are amazing. I mean, they are doing phenomenal work. If we could just give them like that. And a lot of their work is not put out there. And so we were thinking about, could we do like a scholarly newsletter where I send out to the PPLC what is actually happening with the residents and sort of capturing some of that data, as well. So, hopefully for next year.
Two quick things that I want to just mention on top of everything you guys have said, which, you know, I can't tell you how proud I am of the work that you guys have done and the work that you've been able to make happen in this state. I am really curious, have we been getting medical students to these fairs? I couldn't tell from what you said. They're coming, right?
Yes,
People are coming.
they did. So our first fair, and we're kind of stepping into a lot of tech
New
and
territory.
logistics that's very new for us. And so we've targeted third and fourth year medical students who in particular would be experiencing the match relatively soon. There is a thought about how we might in perhaps a different way outreach to first and second year medical students. Again, are getting further into the pipeline of how do we support people along the way. If you look at the data that Dr. Cushenberry and Dr. Serta shared in their grand rounds, the fall off of people that start in perhaps, let's just say high school into college, and it's terribly terribly troubling to see that loss of people that fall off. And that mentoring and the importance of how do we.
So just
support
out of
that.
curiosity, how many folks would you say come to the fair?
So we only had one, and Lucy, correct me if I'm wrong, but there was about 50.
Yeah.
I feel like that's
About 50
a.
students.
50 students.
50,
Yeah,
yeah.
and all of the residency programs at the time. so
Most-
13
most
participated.
Most were black?
They were
All black.
Oh.
So 50 students coming to a mental health, a psychiatry fair for residency. That's gotta be a significant percentage of the black medical students in the whole country. That's,
I would say, yeah.
Yeah.
I mean, I don't have a way to
If
do
we
it right
had
off the top
Ken
of my
Stern here,
head.
he would be able
I
to
was
give us
gonna
the
say-
data.
I don't know the numbers off the top of my head. Yeah.
But that's, I mean, that's just terrific. And we don't know of any other state that's done anything like this that we're aware of.
No.
So you guys know how competitive I am when it comes to sports.
Oh, no.
Right? I'm way more competitive about this.
Yeah.
I want, this is me, I want our state and the work that you guys are doing to, and I think it is, to be superlative and make Ohio and New York and New Jersey, and every one of those places as jealous and like thinking, why the hell can't we do that as we possibly can? So I don't know if that helps or not, I, as a spur to pursuing this, but, I hope we really press this, because it's a really, really good thing. It's a really good thing.
We're definitely gonna do it again. I think we
Yes.
just had to figure out some logistics of like how it works and all
Sure.
of that, but the medical students that showed up said that they would like to have something like this again. And then after the residency fair, we forgot to mention this, but we also had a couple residents volunteer to stay and do like a panel. So then the medical students were actually able to talk to some of the residents as well.
No,
I was gonna say, I was gonna add to that, most of the students, there was a lot from Florida, Georgia, like, a lot of New Jersey, it wasn't just Pennsylvania, and I think we had like 2 that RSVP from like the Virgin Islands, and it was a lot of people from really the East Coast.
That's just so cool.
That wanted to attend, so it was like actually 50 that showed up, but I think it was 70 something that actually RSVP. That was a lot.
Really great work.
Jim.
Yeah, I also echo just it's really exciting to see where, this sort of started and where it's gone to and where it's yielded. I just learned that if you just wait and listen, you get a lot of answers to your question. So I had curiosity about like, what in fact was this group for the residents? And I think I don't want to, break their confidentiality in that domain, but still have curiosity, but you sort of mentioned, I think, with the anecdote that somebody might not be able to stay in residency if it weren't for that. So I'm curious if there's any other little pieces of what the group is that would be reasonable to share. And then also, just with the fair, same thing, I'm wondering, somebody said that if you did something's right, something's wrong. That sparked my curiosity.
Nothing's done wrong, we just had
Or-
trouble with the bigger breakout groups.
Oh.
Technology.
I thought that was most significant.
Yeah.
I think that's, Dr. Dixon response.
I actually was part of the very first resident roundtable.
Yeah.
And it was really kind of just a place where Black residents could feel like they had a voice, they could talk about what their concerns were, how they were feeling about George Floyd, the political climate and all of that stuff. So there really was no like main purpose, it was just a place for Black residents. And just to speak to the work that they've been doing, I wasn't able to attend like every roundtable or be as much part of it as I wanted to, but if this didn't exist, and if people like Marianne weren't here, I might not still be in Pennsylvania. I'm not from here, I've never had any intention to stay here for a long period of time. But I felt like I was in a place where I could grow and I could learn that there were supports. So I'm still here.
Right, that's a testament.
So I'm gonna add, so Dr. Leon Cushenberry and I owe a lot of our mentorship actually to Dr. Francis Liu. Because I know Dr. Francis Liu was his mentor up when he was in University of California. And I met Dr. Liu also, Marianne knows him too, so it's just that like comes together. But one of the things is that I did present this, I'm part of the Idea Committee Association for Academic Psychiatry. So I did actually present this in a poster, who actually like worked at this, was really kind of amazed with it. But I had other doctors come to stop by. I had one from next door to me, who she was doing poster also. It was Dr. Espejo from the University of California, Irvine. She said, we don't have this in our state. So he said. So that tells me that we're doing something very unique, but you're not west, now we're west coast, so they're not west. They don't have this, which is interesting too. So I did get stuff by other people who had like other kind of like psychiatrists and had like specific questions about like the round table and different things that we did. So it was actually really interesting just to get that feedback there.
We're the West Coast without the beach.
Yeah.
Yes.
We're the only other one who got the beach.
So we really kind of, one of the benefits of being part of this group, and I attend because I'm tight, and once in a while I'll throw in a suggestion, but seeing some of the awarenesses pop up in the minds of the residency program directors that wasn't there before. You know, one of them was, well, we would take potential residents on a tour of our facility. We'd show them the medical boardroom, and oh yeah, guess what? Around the walls of the medical boardroom were all the former medical presidents of the particular institution, and they were all white. Well, that needed to come down, and there was not that recognition on the part of the residency program directors before this effort. We have to be jostled into understanding, first of all, our own internal intrinsic bias that we weren't aware of before, and that's one of the things I think this program has brought to the table that is the most valuable to our system of people.
Well, thank you. And really, many of you out there are a part of this, so we appreciate the energy and look forward to future work.
Okay, so we are in the last, we're sort of in the home stretch of this meeting. We're going to do an ICT, an integrated community therapy session. And the trick with this is that we kind of have to figure out how to make it feel a little bit more like a circle. And I'm wondering if the way to do that is have everybody sort of face into the middle with the, and fill up some of the empty slots here, you know. Just so that it looks like, that means you guys. I'm talking about you guys in the back. You can move into one of these settings up, you know, here, double up. It'll just, we wanted to make it look like a circle. I know it's really hard to get people to change. especially where they're sitting. Over here, come on, bring it in. Bring it up. There's seats right here. Turn your seats around. You want to be in the circle. You can do that. Marianne, you can get, maybe if you can find a place where there's, maybe let's try to make it 2 deep at best, rather than 4 or 5. So there's kind of an inner circle and a little slightly larger outer circle.
I'm gonna take your seat.
That's good. Let's see.
It's more oval.
Turn it to, Val, turn it into this, you want to be sitting like that. Yeah, you want to be circled. Stand. You got it. For those people who are online still, this is going to be a chance for you to observe. Maybe we can turn the screen, the picture around. That's set up that way. Do we have, here, somebody can sit here. And I guess I'll need to sit it. All right, so. Anybody want to tell me what ICT is?
It's a lively group.
Integrated community therapy.
Integrated community therapy is the translation out of the Portuguese. Here's a seat here. So integrated community therapy is a method of having a large group, like this size, could be larger even, of people who are going to develop in this conversation, it's a dialogic approach, ways of dealing with particular challenges that they face. The history of this is, oh, we got a seat for you here. History of this is that in the 1980s in Brazil, interestingly enough, this is related. What's the problem?
Now I'm in the way.
You can sit there.
There's a seat right here, though.
We're getting organized.
All right, we got it.
I did.
All right. In the 1980s in Brazil, you guys may have heard this, there was a process of, it's still going on, where they're cutting down the forest, the jungle, the Amazon. And when they do that, the land turns into a desert. So people who were living in that land are now suddenly, they can't grow anything, they got to leave. So they head to the cities, and they go to the cities and they have to basically camp on land that's not occupied, that they don't own. And they create what are known as favelas, right? Shanty towns. And Brazil's famous for these shanty towns because they're enormous, right? So in a favela in Brazil, in the northeast coast, in a city called Fortaleza, which is the 3rd largest city in Brazil, there's a giant favela, and one section of that favela was repeatedly getting knocked down by the police. So a human rights lawyer got involved and was working with them to try to figure out some way to give them some legal status so that the police would stop knocking down their building. These are shanties, right? These are cardboard and, corrugated iron sort of places that people were trying to eke out a living. Anyhow, the human rights lawyer is working with them on that. And he realizes that there's extraordinary social distress and psychiatric challenges going on. So substance use, depression, suicide, domestic violence, you name it, it was happening. And it was just a catastrophe. So, so he called up his brother, who happened to be a psychiatrist at the university in Fortaleza. And his brother said, okay, yeah, sure, send them to my clinic. And of course, they couldn't get to the clinic. They didn't have the money to get to the clinic. They didn't have any idea how to, what the whole thing was about. So that flopped right away, right? And he realized, as I think some of you are realizing in the development of your careers here, that he had to actually go to the people, right? The psychiatrist did. So he said, I'm gonna go out to the clinic or out to the favela. He takes a couple of medical students and he goes to the favela and they announce that he's coming. When he gets there, he finds a line of over 100 people standing out in the sun. There's no building to meet in. They're just out there in a line waiting for him to show up. He shows up, and the story he tells, I think it's a bit apocryphal, but I think it's pretty close. Interestingly enough, I heard this story, and that's why I even knew about this possibility, and I'll talk about how I came to it in a minute. But I heard a sort of attenuated version of the story. What happens is that he goes to the first person in the line, it's a woman. And he says, you know, how can I help you? And she says, I can't sleep. I just can't sleep. And he says, well, I've got, you know, he's thinking, I got 100 people to see here. Let me give you some medicine, help you sleep. And she says, don't even bother writing a prescription. Like, I'm having trouble feeding my children. How am I going to buy any medicine? I can't do that. And he's like, the word, he would never say this word, but the word was, oh, what am I going to do? So he sits and he's contemplating that. And one of the people behind the woman in line starts to rub the back of her neck. And another person runs off to, there's a little tienda there that, you know, little sort of bodega, right? And gets her some tea. And then somebody finds her a chair, there's a loose chair around, they give her a place to sit. And they take care of her. They take care of her. And the story then emerges that her husband had been shot in front of her about a month beforehand. And she's just catastrophically been, you know, dealing with that. Adalberto Barreto, who's the psychiatrist, realizes, as he describes it, that his capacity to be helpful to this community with his usual psychiatric knowledge was extremely limited, given the circumstances that they were in. But he said, even more importantly, he realized that within that group of people, which had all these problems, there were also all kinds of solutions, and that the capacity of the people to take care of each other was much more significant than he had paid attention to. And that the reason that the people were not able to take care of each other, that they didn't have this whole infrastructure already built, is because there's so much stress and strain on people, so much atomization of people, so much fragmentation, that they couldn't make the connections, and that the job that he had was going to be with the favela to help them make these connections and develop what they call solidarity care, as opposed to what we would call clinical care. So clinical care is you've got a professional, takes care of people. Solidarity care is peers working and connecting with each other. So he starts this process with the favela, and over the next 40 years now, they have they've developed this method. I'm going to do a kind of attenuated version of it with you all, just so you can feel a little bit about what it's like. It's in 40 countries. We've brought it to the United States. The reason I brought it to the United States, I mentioned I'd heard the story. About 25 years ago, I'm not really sure, it might have been even earlier than that. I heard a story about, because I was really interested in, you know, I'm going into my clinic every day and I can see, you know, if I really stretch it and I work very, very hard on an individual level, I can see somewhere around 16 to 18 patients a day. And I'm just wiped out by it. And I like, oh my God, and then I go up, I get up the next day and do it. But you realize that over time, there are so many more people waiting to get in, let me in, let me in. And I'm sitting there, I've got a tiny little space for you to crawl through to get to me. You know, there's so few who can actually get to us. So I was looking for something that would move it to a larger scale. And I heard about this guy in Brazil who was doing large groups. In my mind, I imagined he was in like a high school auditorium, because I thought they had buildings, but no. And I learned about a guy, and the story I heard was that he went in and he asked what the challenges were, and they said, then somebody said, I can't sleep. And then they had a long discussion about how there was all this racket noise, there was stuff going on in the middle of the night, and it was a community problem. So that actually also happened. There was a community problem because in the middle of the night, people were getting up around, they had to, as a community, come together to solve that problem. So it's not always about individual problems, it's also about the larger communal problem that they have. So now the Brazilian Health Service is funding this initiative. And they did that because it turns out that people who participate in ICT frequently have their issues resolved enough so they don't have to go into specialty services. And when there's a huge press for specialty services and limited resources, you get the challenge of like, they have to wait forever. And everybody's sort of squeezed all the time. So they now have these ICTs running all through Brazil. I run into Brazilians and they will tell me, oh yeah, I participated in ICT. It was really good. I really enjoyed it and found it very helpful. So I believe that it's actually out there and in practice. It's usually done by community health workers. So it's done by people who have not professional degrees or sort of more lay people. And you can train people to facilitate this method fairly easily, although it does take a little bit of time. So anybody have any questions about all this? With COVID, we got in touch with, I was able to actually, because I'd been to the UK and run into some Brazilians there and asked them, you know, does this thing actually exist? Is there such a group? I had learned that he did in fact exist. And we were able to find him and have a conversation with him. And we did some trainings here over online to train a cadre of people. And now actually in Pennsylvania, we have a large demonstration project being run out of the Lehigh Valley, through the Lehigh Valley Hospital. So, and we're trying to bring it to got some people trained, but we're trying to develop a solid base to do it in Allegheny County and then hopefully elsewhere. So any questions about all that? All right, now, what I'm going to do with you guys is I'm going to do what's called a thematic ICT. It's a little different than the traditional ICT. A traditional ICT, what I would do is I would say after a welcome and some stuff we're going to do for a second, I would say to you all, who here, after saying it's very important to talk, when you talk, the Brazilians say, when the mouth speaks, the body heals. And if the mouth is silent, the body is ill. Okay. I would add the mind as well. If the mouth is silent, both the mind and body are not good. We would say, who in this group has a challenge that you're facing, an emotional challenge that you would like to share? And I would quote you a saying by Muhammad Ali, which is, it's not the mountains up ahead of us that wear us down, it's the pebbles in our shoe. We're not looking for secrets. We're not looking for anything like, you know, stuff that's really deeply buried. This is a group that's public. It's held in a public place. We're not trying to make it very isolated. You can do it in groups that have secrets, but everybody in the room has to be able to handle the secret. And we're saying, you know, you should share things that we're not asking people to be confidential about it. And you can share things that you're comfortable sharing. If you don't want to share it, don't share it. if there is something that's on your mind, the facilitators are trained to be able to, at the end of a session, talk with folks about more specific challenges that they've got and make referrals for them if they need it. So that's how we handle the sort of sometimes the more deeply held stuff. In this particular case, instead of collecting stones or pebbles from you all, let me just say a little bit more about the pebbles. I would get 4 or 5 people to give me a pebble of a challenge that you're facing in your life right now. And then I would try to extract like exactly what the challenge is at the most basic common level. So for example, you say, I've lost my grandmother. I'm really depressed and very sad. Not everybody in the room has lost their grandmother. Not everybody is right now in a moment of terrible grief from a loss of a loved person like that. But everybody in the room has suffered some significant loss important to them from a person, could be an animal, whatever, that they still carry with them. And I would say, okay, so what you're talking about is the sadness of losing somebody in your life that's really important, or something in your life that's really important. Condense it down to that. Then all the pearls in the room, or sorry, all the pebbles in the room, I would do that for each of them. And then the group would decide which one of those pebbles really was the biggest issue for the group as a whole. So it's an exercise in democracy, in the sense that everybody decides what the largest issue is at that moment. It does mean that not everybody gets talked about. And that's actually important because part of this is the formation of a collective in which there's some way for people to prioritize as a group issues that they need to talk about. And not everybody all the time is first, right? But we will say, if you have it, bring it back. We'll get to it the next time. But we're not going to do that because it doesn't have time to do that. What we're going to do is what's called a thematic. And the theme I want to pick today is in regards to the whole conversation all day long. I think, let me see if I can say this as concisely as possible. I would like to ask people to talk about the feelings that they have that make advocacy challenging, difficult, and what they have done to overcome it, to overcome those feelings. Is that clear? Feelings that you have that make doing advocacy difficult. Now, some of you might say, well, I do advocacy all the time. Then I would say, what stops you from doing it at the next level? What's the challenge that you have at the next level emotionally? And I would like you to speak with your feelings. And let me just give you what the rules are, okay? So when somebody's speaking, everybody else is silent. You talk about yourself. This is the most interesting thing. You can only talk about yourself. You can only talk about yourself. So the fascinating thing is that making a group that exists by people only talking about themselves. No judgments. Don't make interpretations. Don't make speeches. I said already, don't share secrets. If we had more time, I would have a little bit of an exercise right now after having read these rules to you. And I would say, okay, we're never going to forget that it's more than just our talk. It's actually our expression. And I'd say, let's play some music. Something from the culture that we are all of. Something that has some meaning. Somebody could choose. I could ask somebody to, if you've got a poem that you would like to recite or something you want to say, anything that brings the culture in. And then the other thing we would do is we would also stand up and move around a little bit. Okay, in fact, everybody should just stand for a minute.
You're setting the bar low, which is good.
Well, the fascinating thing is in Brazil, when they do this, they will play music and they don't have to cue it, nothing. Everybody just, they're like dancing And we will beg people, could you, please, we're gonna put on some really good music here. Could you dance? And I have to say, 9 out of 10 Americans just cannot do it. There are some subcultures that go right to it. I'm not, you know who they are, who we are. But some cultures just so frozen. So anyhow, okay, just move, reach around, stretch, just let's get back. You have a body. That's the main point of this. Don't forget that ever. It's there. Now you can sit down. And we're going to start off, I've already given you what the task is going to be, the thematic. But to just start off, does anybody have anything that they are appreciating, especially that they would like to let the group know about? Anything going on in your life that's something that you appreciate at this moment? Any appreciation or celebration, something you want to celebrate?
I appreciate just being here today with everyone here and my experience through the weekend where I've got to be with people who are sharing their voice and interested in community work.
Perfect. Anybody else have an appreciation or a celebration?
I want to sort of dovetails on what Mary Ann said, but it's just being in this group and seeing a lot of newer faces that weren't here 8 to 10 years ago when I was here. And it's so wonderful to see, especially the residents and the young psychiatrists, early career psychiatrists and other administrators in mental health really coming in and embracing the world of the people that we all care about.
Anybody else have an appreciation? Yeah, Val.
I want to show my appreciation for all of those who participate in this group, who have used their expertise and their volunteer hours to further the causes of the things that we feel passionate about. I know a lot of the work that gets done by people in this room go unpaid. And I respect that greatly because you're pushing things forward, you're growing really important aspects of the profession and the system, and I'm just very appreciative of that.
Thank you. Yeah, Jim.
And I have an appreciation for that this group addresses how to help mental health issues that isn't about a prescription pad. Right. And it really is, takes a look at the larger, including this.
Well, in fact, this whole method we're using right now happened because the prescription pad wasn't going to do it. So I'm going to make a point, the facilitators are just facilitators in this method, and we're actually participants. So I'm going to have an appreciation, and I'm going to tell you, one, I'm very appreciative of being here and able to be here. And I am really appreciative of the care that I got in the Netherlands that got me through all this. And I would routinely say to people there that I had an extraordinary attitude of gratitude to the Dutch people. And Mark, as an extension, you can hear this. And I would say this to my basically, I said it to everyone I could. I was like, it really expressive about my gratitude because I felt it. And I just got the same answer back every single time. And it's just so humble and so meaningful. What people would say to me is, it's very good to hear that. So the reward of doing a good job, taking care of people is just, it's good to hear it. So I'm very appreciative of that. So let's go to, let me see if there's any other step here. Well, should I talk? And what I said before, when the mouth speaks, when the mouth is silent, the body speaks. And what to talk about? Well, we're going to talk about whatever is a barrier to you emotionally to doing more around advocacy or concerns you about advocacy, what that is and how you overcome it. Who wants to speak? Who has something to say?
Oh, we're not doing this like partner, it's like the whole group?
Whole group?
Oh, everybody talk. Gotcha. No, I just thought it was Alicia.
Are we working off of your original question?
Yeah. Yes.
Okay, just maybe I nodded along when there was something else.
So I guess I'll start. A couple times today, it was mentioned, imposter syndrome, feelings of inadequacy, not knowing enough to really speak up and say what you think about advocacy, or like not feeling supported or seen, or like your voice really matters.
So how do you overcome it? That's the key part. Key part is, what do you do to overcome it?
To overcome it, you know, seek out supports, get the knowledge that you feel like you need to learn in order to be an expert, or even a novice who can have a voice in this.
How do you do that?
Well, I reach out to Marianne often, honestly, it's my personal method.
Good, okay. Anybody else?
I'll just dovetail. I'm smiling because I have, I'll put it out there, although I stepped into this effort of advocacy by agreeing to go to a hearing last year. And I got through it, face it, feel it, get through it. I have not reached out to my legislators. It's an area of fear. So people are coming to me for support, and I'm going to come to the Concertas and other folks that do this because I need to do it. I did make some calls and they went flat. And then I'm like, okay, and the summer got busy. So it's, I don't know whether it's just fear or trust in them or trusting myself. And I do have, obviously this morning I had some strong feelings around aggravation around the process.
Okay. Anybody else?
So when it comes to emotions and control, so I've been working with people for many years, more, just not always on the family side, but for other things, although to me, they're all intertwined. I've had to work on how not to respond when people say things around families that I've heard for over 30 years, and they're still saying. So I have to work on that because I get angry. I'm like, do I need to talk to everybody in the state to straighten you out? But it's not seemed to be like no one's actually understanding why families do some of the things they do. They don't. I get aggravated and upset because they don't think we're worth the time to find out. And we're frontline. Even when our children no longer live with us, who do you think they're calling? That's it. And that we're never seen as that. We're seen as other people gonna have to come in to provide support to them because somehow that we have no expertise around the people we love and have raised all their life.
So how do you overcome?
Well, I know ahead of time, some of the people I'm gonna meet with it, it's gonna be there. Someone will say, oh, we wish all families were like you, Chris. You wanna separate me from the work that I do. It's intentional, whether you realize it or not. But it's, I know some meetings up front, I'll hear it, but I have learned not to show a reaction on my face. I've learned to take a deep breath. Sometimes I'll say, well, let me think about that for a minute. When you hear me say that, I'm just trying to figure out how not to raise the tone of my voice. Because whatever I say or do will impact any family member that I'm just impacted how they see families and what. So it's very important. But yeah, I mean, after all these years and I still, I'm like, what is wrong with you people? Don't education talk about it? Are you not trained that families are real people who have other things going on in their lives just like you? So.
Then they take 24/7.
Okay. Good. Anybody else? Other blocks to advocacy?
I think, I have two major blocks. It's, one, lowering my expectations for myself, because I can be very hard on myself. And I think the other is, navigating how to build a stronger sort of support system in the sense of, advocacy. Meaning, there are some people that I work with where we don't have the same work ethic, and it has been more hurtful than helpful in the advocacy work that I'm trying to do. And so one way that I have overcome that is that I have surrounded myself with people who are more action oriented to then delegate tasks to them to help support the work that I want to do, if that makes sense. And creating realistic time frames based off of not my work ethic, but off of the person who has, and I hate saying this, but a lower work ethic than I do. Because in that way, it helps me not only help amplify them to try and get them to do a better job, it then helps me not be so hard on myself if I don't accomplish something by a certain time.
Anybody else?
I don't know if you can hear me. I guess being an immigrant was something which I was, I mean, at least initially hesitant about, like, getting into advocacy. But I guess I did my fellowship from DC. So there I kind of attended many ACAP advocacy conferences, and there I got to, participate into advocacy so much that I was able to get through that. Okay, even if you are a international medical graduate, you are able to participate in advocacy, and people welcome and hear you. So I guess more participation and more support from the group kind of helped me get that. But I had that question, like, as an international medical graduate, can I participate in advocacy?
Go ahead.
Can you hear me?
Now you can, go ahead.
Go ahead.
What I understand you to be saying is that you just kind of grinned and bear it, and you went in and you found it not to be as frightening as you thought it would be.
Yeah, exactly. I mean, I was hesitant. I was not sure whether, I mean, how much I could participate. But then once I got to participate, I got more comfortable, and it was like, okay, I mean, people here, you can go like and meet people, and it's just a regular interaction.
Right.
So I got more comfortable with the support and with the regular participation, and me being in DC helped a lot actually for that during my fellowship.
There. Anybody else? Yeah. Ralph.
I kind of struggle with, when I want to do something, just taking on everything that needs to be done, whether it's like web design, marketing, like, you can't do everything. But then also finding, like, Sierra was saying, like, people that I can rely on to do things and trusting that they're going to do it. So it's like this balancing act where it's like, if you're not going to do it, then I'll just do it. but like, if you're going to say you're going to do it, can I trust you to actually, and then step back and hand over the control to different ones.
Okay.
I don't know how I overcome it. I try to collect, not collect, that's not the right word. I try to meet people and talk to people and surround myself with people who have proven to me that they can do things. And slowly over time have a group of people who are action oriented. So.
Okay. Good. Yeah.
I feel a frustration that I might have been doing the wrong thing all the time. For instance, it's like writing letters. So I was writing letters to my senators and so forth. I get this like feedback from them. It's like the system probably gives you like a general, like, we received your letter and this is it. But perhaps that's the not knowing part. How am I overcoming it? I think I just learned how to do call them, figure out if I can get like a person sort of interview of some sort with them. But I did not know that. So that might have contributed to my frustration.
Okay. Jim?
Yeah, my frustration is that, I don't really feel like it's gonna matter, it's too big of a problem. It's not really where my energy is. And what I find that I do is to spend time in the trenches but to see advocacy in how you relate to a complicated system. To sort of go ahead and get that pre-auth, or make sure that the system gets the feedback that this didn't happen. You don't always know the direct result of that, but that's actually a version of system change and advocacy.
So you, if I understand what you're saying correctly, you, from the trenches, you act to make sure folks know what is happening in the trenches.
After being in a place of like, what's the point? Nothing's gonna ever change. Why bother? So easy not to do some of those things. Really is. But if you do them.
My experience is that sort of surprisingly to me, is many people will just stay in the trench and not say anything about it. And I think the notion of the trauma that we heard this morning made an awful lot of sense to me, that people are just like, I just can't bear the thought that I'm gonna not have my thing responded to. And then they don't. And then once I don't make things happen, well, that's a guaranteed way not to make things happen. You guys in the back there, the fellows and faculty, anything that you would like to add to this? You know, if you keep your light under a bushel, nobody will see it.
I think I can reiterate, what some of the other people have said, which I think I share, like lack of confidence, both like in my own knowledge and like awareness of the process, and also the effect of my actions and whether it's worth the energy or time. And I think how I overcome it is I keep trying to show up, even though I feel that way. And I try to think about other skills that I bring to people, even if I'm not like speaking out about something, but like listening and asking questions and reflecting and trying to figure out how to.
So I'm basically being a bit more assertive and or action oriented in terms of dealing with the insecurities. Did I hear that correctly?
Yeah.
Okay. Anybody else? Any other?
I have an example. It's like what I initially thought was like field advocacy. The previous team I worked with, understaffed, underpaid, overworked. And I brought that up during a meeting and with people like that higher in the organization. And it got a bit emotional. And the next day I sort of got called on the carpet. I was told to stay in my lane as a doctor. That, you know, these were like organizational issues that I should not be, I guess, messing with or read about. And so although nothing changed at the organizational level, it did make us much more cohesive. I think people felt heard and seen, and I think it helped us through like, you know, a pretty difficult time.
How did you overcome that? Because, you know, them trying to keep you in your lane.
So I decided to focus on, like, I mean, the reason I spoke up is because I cared about these folks that I work every day. Like throughout COVID, I mean, so yeah, that's what I decided to focus on them. If I can't change the organization, I mean, I can support that. And that's sort of more like, you know, personal advocacy on this.
We often think that advocacy is going to be about changing things because it changes the power. I have to say this, in I language. If I use the word we or you have to call me on it, okay? And I will do the same. I think about advocacy as changing something in the power structure. What you just described is a really interesting element to this that we haven't really talked about. And I really appreciate it. I think if I understand it right, when I advocate, the impact isn't always just on the people I'm trying to change. The impact can be on the people around me in terms of continuing to make connections and sort of indicating solidarity. And if I didn't do that, I would be, in fact, sending a message of not solidarity. So I think there's another level to advocacy that you've just described that I hadn't really considered. At least not until you said it. So thank you. Yeah.
I think, I've always struggled with this idea. I've thought a lot about like CBT and whatnot, but it's this automatic thought of, I don't know what I'm doing, right? Kind of the imposter syndrome. And so I think when I reflect on what I've done so far, I've always just phoned a friend in response to that. And I think it's so much easier to advocate with someone else. It's almost like a check, like, is this an okay idea? And then, you get that validation, and then it's almost, you're no longer by yourself. And I think that has been really helpful.
Yeah. Yeah.
I think for me, something that can be a barrier is just feeling like I'm not doing enough, especially like coming to places like this where I hear all the amazing things that people are doing. And so I'm not like writing letters and like going to meetings. And I think to overcome that, I try not to minimize the things that I do on an individual level, like even just patient to patient, like even, calling the insurance for the prior auth. For me, that's annoying, but like if the patient were to call, they wouldn't get anything done. But when I do call and I can get the prescription, that's like has a big impact on the individual.
This is a really key thing. In pressing for more advocacy, I don't think the environment that we want to create as a group, this is me speaking to the group, so I'm just going to make this as is not one of expectation. It's more of opportunity, if that makes sense. And that's a challenge, because for myself, I feel like if there's an opportunity, I really should try to take it. On the other hand, I recognize that there are limits to what I can do. And to some degree, that the standing up and being in your body thing that we just did is actually just an effort to kind of keep in mind, because our minds can be much more expansive, but our physical beings are limited, right? I really understand. And our day-to-day lives are limited, right? There's only so much I can do. And I appreciate that. And recognizing that is a really critical skill and thing to be aware of. So thank you. Anybody else? Any other? You look like you were going to put your hand up.
Oh, yeah, I thought you were going back. So I think two things for me are time and perfectionism. So I think the other aspect with time is that most of us have other roles in our lives besides just that of mental health provider. I'm a parent, I'm a wife, I'm a daughter, a sister. granddaughter, you know, so there's a lot of other, I'm a assistant baseball coach for my son's baseball team, which is pretty time consuming. So there's a lot of other things that pull at our time and are important. And I think about sort of, you know, making impact in my little community or neighborhood with some of those actions too. And then the other piece is perfectionism. Like if I can't do it really well, then I will decide not to do it at all. And so those are both things that I'm working on.
How do you manage those two things?
Oh goodness, you know, it's an ebb and flow. So I'm trying to embrace the language of good enough. I think like with the other roles, because there's so much as a psychiatrist that like it could take over your entire being, your entire life. The work is never done, right? There's always more to do or more to learn, more people to treat. So I think also just stepping back and realizing like I'm a human being too, and like I have to take care of myself and I have to take care of the people in my life that are important to me, and that I deserve to be able to do those things and also to have some fun along the way.
So much of what you just said just hits me, right? But for me, it has to be more than, you know, good enough. I actually had to get to the point where I think that perfection is the enemy. Right? There's a great saying that I learned a long time ago, and it still sticks in my head. Perfection is the enemy of the good. And that was really important because for me, the expansiveness of psychiatry, of all these roles that we have in our lives is so crowded. And you can't attend to everything all the time. And sometimes the baby just has to cry. Sometimes the baby just has to cry. And in fact, if the baby doesn't cry, that's worse. Right? So that's a hard thing for me. That was really hard. And the only way I could do it was, I've been able to do it, is because perfection is the enemy of the good, and I do the best I can with the things I can do. And I hope that I get what I can get done. Turns out a lot of stuff doesn't have to be done, although my wife thinks differently. Anybody else have, I shouldn't pick on my wife. That was really more of a throwaway husband line. Yeah.
Sometimes when I sort of, it's not having imposter symptoms, sometimes I'm afraid to say something because I don't know if it will be accepted by the group or if the group will understand it. And sometimes the way I get through it is sometimes it just pops out anyway. And then other times I realize that the other people need to know what I'm thinking because there's something they don't get and they can't get it from their perspective. They will only get it if I say it. And if I don't say it, they won't know, and that will be a missed opportunity for them. And so that helps me say it.
That, looking at the time. There's one more?
We have time?
Yeah, we have time.
So I similarly struggle with like the whole imposter syndrome around things. And then with that, a lot of feeling lost, where I care about something, big issue, maybe I know some stuff, but the worry, right? All the little things I don't know about. Oh, even if there's a bill that I'm like, I like this bill. Oh, well, who are the back doors, things, all this stuff that I just don't have the time, resources, and frankly, even if I had unlimited time, I would have no idea how to find this out. What I've been trying to do to deal with this is joining, like getting involved more in professional societies over the last year, which is on some level, frankly, reinforced it for me because I come into groups and I'm like, well, you know, this is sort of a working machine to do whatever it's currently doing is what it's designed to do. And it's certainly doing it. And, maybe I'm not so welcome in that space. And then at other times has showed me to instead kind of rely on more individuals and relationships with them. Because I've met some really wonderful people who then I can, text and say, hey, I'm not sure about what's going on with this. Have you heard? And we all kind of text each other and or talk about it. And then that's been sort of the cure for that for me. Is focusing more on the individuals and less on, the groups that I'm kind of told, yes, this represents you, but we're not really interested in what you have to say.
I have an experience of, I go to conferences, right? I just realized that, I've gone to 40 years of what was called the Mental Health Services the APA's fall meeting. 40 years I've gone, except for the 1 year with COVID. I've gone to this meeting. And I would say for me, 90% of what I get out of that is the connections I have with the individuals who are there. Not necessarily in an individual context always, but it's about being in that connection with people for me. So I completely appreciate what you just said. We have a couple minutes, and what I would ask is that to sort of round this out, we've heard a lot of really challenging things that people face and ways that they overcome it. Is there anything that you heard today that you're going to carry with you after this into your own lives that you're going to think about or that it reinforced in some way how you've been dealing with issues and challenges that has some meaning to you? And if so, if you'd like to say it and to express that attitude of gratitude that we talked about before, are there things that have some gratitude that you heard in what was said today? And if you can say what that was, that would be great.
Gratitude in knowing that I'm not alone and feeling the way that I feel about advocacy, and recognizing that even the people who I turn to also have questions and their feelings of inadequacy as well. I do want to share a quote that came to mind while we were talking. It's actually from a British comedy show called Peep Show, and it kind of rewired my brain. The world is just people walking around, going into rooms and saying
That might be our motto. That's what we did today. Anybody else have gratitude, things they would like to? Yeah, Marian.
Just thinking about the role of, what our hats that we wear and our roles and responsibilities, and shifting back to feeling quite grateful for family, and family as defined by the folks back home that allow me to come here and hold the fort over time, and that shifted over time, but grateful for that, and grateful for my family of workmates and colleagues. So that both of those, and I think earlier what comes to mind, and I don't have it right now, and it troubles me. I had a bracelet that said grateful on it, and it broke last week, and it drove me crazy. It was something that I was able to have following my father's death, and that was his word, gratitude and gratefulness, and it really drove how he organized his life.
So beautiful. Yeah, Jim.
I'm grateful for mentorship, and I'm thinking of one of my mentors who was a group therapist, and what you said, Kathy, reminded me of what she would say, which is, you don't have responsibility for what a group will do with information you bring. You only have responsibility if you withhold it. And I see that impacts advocacy too.
Anybody else?
I'm just grateful that I'm here because last time, or last session, let's say through the PPLC, we talked about ICT and that we should actually like carry this out. So I'm just happy it happened. That's one thing.
Me too.
And I'm actually kind of grateful also that this could be also used in other places, also other spaces to actually help with advocacy, just like we're seeing it now. So experiencing it helps me to share it also with other people.
Thank you.
I'm just grateful, to be part of, well, for the sort of the attitude of vulnerability and genuineness that people brought into this space. And I think, like as an attending, I try to be, quite vulnerable and open with my trainees a lot of the time. And I think once we sort of get stage in our career where we are the attendings, we don't have as many opportunities for that. So I'm grateful for hearing other people's perspectives today and wishing for more opportunities.
Now, in Brazil, what would happen at this moment is everybody would stand up and we would get in a circle and put our arms on each other's shoulders, and we would just rock back and forth. And we would say, you feel the support of all the people in the group, and we can rock back and forth, and we're not going to fall down because we are all held up by each other. In the United States, it's very difficult to do that now, and it's a shame. I don't know what we're going to do about that, because it really is a fundamental element of the history of human beings, to be in that kind of connection. And what we do to get rid of the fear that we have around that and make it possible that it won't be abused is really a huge challenge to us. But I'm going to call the ICT to a close at this time. You guys have had a chance to see a little bit what it's like. You know, obviously the key thing is that people learn how to express themselves. So it's emotional literacy that you have to develop to be able to say something about your feelings, right? I didn't ride you guys real hard about making sure everything, and I didn't do it for myself, was about a feeling. And sometimes we can really have to drive that because people bring more concrete things rather than feeling. But to express feeling, and critically, as you heard, what you've done to overcome or manage or deal with those feelings. And in doing that, what happens is that people who are in the room with you learn from you how you have managed something. And it increases their repertoire by hearing that, because there are ideas and things that you will hear or reflections, or you may just get reinforced, which is also very helpful. As you were saying, it's good to just know you're not alone, right? A hugely powerful thing. For people with psychiatric challenges, you know, the biggest issue usually is not the symptoms. It's the sense of feeling isolated and disconnected. And this creates the sense of feeling connected, because it's what happens. Fascinatingly, as I said, it's all done by talking about yourself. And we do that. Anybody have any questions or reactions or anything that you want to say about this experience beyond what you've already said, which is a lot of gratitude, which I really appreciate. And I'm glad that's part of the process, because it always ends on an upbeat. It's good.
I thought in my head, maybe like I think it was about one helping the other one, but I figured out now you're supposed to help kind of yourself, and then from there, solidarity kind of builds.
This I do for myself. You got it.
Is there any place, sort of a next step, or any other projects that are going on, or any, just curious about any next steps? Both for IC, for ICT.
For ICT, we are working really hard to what I've learned is that, to bring in a new method, you gotta find somebody at a systems level who wants to try something different. We've tried just, training facilitators. But it is hard to organize groups unless you have some sort of organizational base to do it from. So that didn't work to just train people how to do this. Where it's working right now is, as I mentioned, the Lehigh Valley Health System. There's something called the Pool Fund, which is a foundation built on innovation. So they've paid for us to bring, train people and to run a wide range of groups all over the Lehigh Valley. And it's gone really, really well. So we're looking for that kind of sponsorship right now, but it's really challenging. I mean, if I, this is very well published in Portuguese. And it's been widely accepted in, other parts of the world. It runs a little bit counter to the grain in the United States because it's not about an individual clinical intervention, and it's not about a pill, and it's not about something that you can make money on, right? But I think if this has been at all helpful to you guys to understand it, you could see how it would be possible in communities across the United States for people to assemble and to challenge and to deal with some of the challenges that they have without costing them a lot of money, without having to overwhelm clinical services that would allow people to sort of figure out how to manage their lives and use different techniques than they've learned, and also to feel connected all at the same time. So we're hoping to spread it and to get it. It has mental health recovery aspects. It has mental health promotion aspects. It has community building and solidarity aspects. So we're hoping to get into all those different kinds of venues, from youth all the way to older. In fact, interestingly enough, it works better the more diversity you have in the group, both age, gender, race, ethnicity, all that's the class, everything. Because there's so many different approaches that people can take that they bring in, the more diverse they are.
Is the current effort in Lehigh system in person, virtual?
In person.
In person?
But they do both. We can do both and have done both. We have two trainers from Mexico who, the English speaking, who've been really engaged in that, and we're hoping to bring them back to the States and maybe do some more. So that would probably be online. There will be opportunities to learn how to do this online.
Do you see it as a value for immigrant populations?
Absolutely.
Yeah, because I guess I'm just thinking in Erie, we are a resettlement community, and is this a way in which we can outreach differently?
I mean, any community, it was in a favela.
Yeah.
It's the communities that have the least, that have in some ways the most, and there's a lot that can be gained when people have the opportunity to connect with each other. The favela, that's an interesting point I should mention. The favela, which was all, shanty town and in terrible shape. Both, in terms of the built structure and the people. The favela is now a go-to place in this area for wellness and community development. And large numbers of the kids are going to college. And the houses have been, the shanties have been replaced with, it's a bricks and mortar community now. So I don't want to say that that's totally ICT, but I think that for people to work together, we get asked a lot, from the political side,
well, are you trying to teach people how to, work together to solve a community problem and seek community power, right? And the answer is yes, but it's not like it's about, we talk in this group, that you might say, we're getting taxed all wrong and we should, nobody's coming and giving us jobs. Let's go down as a group to whatever politician and protest. That can come out of ICT, but ICT's first purpose is to help make sure that people are connected to each other. That if there's no connection between people, there's no joint action. And if that connection isn't emotional, if it isn't about being, it can't be purely rational, it has to be about, I love you, I care about you. If that connection is there, then the power of people to work together gets magnified hugely. That's the theory. It's built on the work of Paulo Freire. I don't know if you guys are familiar with Paulo Freire. Younger folks, you guys heard of Paulo Freire at all? Okay, so Paulo Freire, you have to check him out. He was a Brazilian, actually, and he wrote a very famous book in the 1970s called Pedagogy of the Oppressed. And his whole approach is that everybody is a student and everybody is a teacher. And it is in the process of sharing a dialogue that you build capacity and capability in people. And this is really that Paulo Freire applied to emotional life. That's what this is. It also involves, you might be able to detect, it's a little harder to see when we're in this kind of a room. It also involves wisdom out of indigenous leaders, so there's long history of healing circles that human beings have engaged in everywhere, all over the world, as well as some of the communication theories of people like Gregory Bateson. I don't know if you guys have ever heard it. The idea being that people who are in communication with each other are in a process of development that evolves with time, and is based on the fact that they are in fact communicating. So when we set the place for people to communicate, we are building human infrastructure. Anybody, any other thoughts, questions? We are almost at the end here, so I don't want to, I don't know if there's an end point that we need to say, Val, and other summing up the day or other things like this.
The good of the order. But we have a minute or two for questions, but we should end
pretty soon, yeah.
I'm just thinking we should advocate for some open spaces where people can get together, but it's too current, I'm thinking lacked up spaces where you have like different generations kind of getting together. We don't have that. It's not like going to like a little plaza like in South America where everybody meets with each other and they're walking around. Everything's in the center of town. Well, let's say that we're sort of separated by great lands between.
We got a real issue with how we don't actually exist around other people. It's a cultural problem, I think, for the United States. And it's really evident. I mean, I had this weird experience of having my grand European adventure while I was recovering from my heart attack. And so I would never want to do this again in that circumstance. But what was fascinating was how much people exist in public space and how little of that is here. It's really striking. And you're worried that it makes people disconnected, and when people are disconnected, then they don't care. And there's sort of this, feels like this death spiral of disconnection, which I think, by the way, this election is at some level about, personally.
When you look at our architecture, right, we bring everything that we used to go to into our home.
Yes.
We have a home theater, a home spa. So our houses get bigger, and we get more room.
Right, and the Netherlands, not to pick on them again, but Everybody's on a damn bicycle. But you could bicycle anywhere and everything you need is within a bicycle ride. Which, so they're fit, they're, I don't want to go there, but, yeah, so I do think that part of our work has to be to think about how we are engaged with the culture and the structure of our interactions. That psychiatry is not going to do well the more disconnected and unconnected we are. I think that ends up not doing well for people, to keep them from getting ill, and once they're ill, getting them back to feeling better. So I don't know what we do about that, but maybe this is a piece of it.
Well, I see it leads to the roundtable in the community that's been developed for residents.
All right, do you want to say anything at the end here?
Yes, first of all, I'd like to thank both Lucianne and Deb for their help. Thank you to the COE and Friday morning group, and thank you to all the presenters who presented today or helped facilitate. I really appreciate you. I do want to make just a few announcements. If you're interested in getting involved in the Racial Justice Learning Collaborative work or the resident work, that's Monday nights from 6 to 7. Even if you can't make it every Monday night, I think Mary Ann, Crystal, and Sarah would be happy to see you. So you would reach out to Lucy to get that information. If you'd like to come to our general virtual online hangout that usually emerges into something advocacy related, usually that's every other Thursday. So that's the second and fourth Thursday of the month, again, from 6 o'clock to 7. If you're just interested in anything, still reach out to Lucy. She could get you connected to anybody here today. And again, if you're free for that meeting with Representative Mike Schlossberg to talk about the Mental Health Procedures Act, that is next Thursday at 1 o'clock. Lucy also has the link for that.
And you're meeting with them virtually?
We are meeting with him virtually, yes. Which means that if you're in Pittsburgh or Erie or Philadelphia or Dolphin County, you can join us and we'd be happy to have you there.
We are also continuing to look for, more people to
This
be
Thursday,
engaged.
this Thursday.
We're looking for people to be engaged, so, fellow residents or other folks that you have contact with who you think want to be engaged in helping this state be the best state that we can possibly have, particularly around mental health. Feel free to let us know about them and we'll invite them to participate. Anything else? No? Thank you all for coming. Thank you all for your participation in this and in the whole day. And those of you who were able to come last night. Fantastic. I had a fantastic meeting. I'm really appreciative. We're going to meet again sometime, but we don't know when
We're
yet.
looking at April for our conference. So stay tuned. We're going to start discussing that probably this Friday.
And I will say that I hope that some of you will share what you have to say about work you're doing at that conference. So we have an opportunity for everybody to participate, and we're all shaping this world together. None of us are doing it by ourselves. So everybody's welcome, and look forward to seeing you guys in the flesh in April and hopefully online in between.
And the last online opportunity, may not be the last, but I'm gonna give a shout out to Wes's, the Center for Public Service
Oh, yeah.
Psychiatry webinars.
Yeah.
The first and third Thursday from noon to 1.
They're great.
Yeah.
Give
CME,
yourself CME.
CME loaded.
They're very good. All right, thank you, guys.
Thank
Thank you, Doc.
Thanks, Ken, for being the